Right. So very good morning, everyone. I'm Professor Yeong, and I'm very glad that all of you can make it to one of the event I would consider highlight in our history within UC Science Malaysia. So we have today a good friend of mine, Associate Professor Kewin Siah from National University Singapore. So the whole idea really is to have a DGBI study day where we wanted to provide some update on the disorder of gut-brain interaction, or previously known as the functional GI disorder. Now, I would say that a lot of us know Kewin very well. He's very active in ANMA, the Asian Neurogastroenterology Association, and definitely play an important role on the development of DGBI within the Asia Pacific region. A close man at heart, I know that he loves food, although physically in Singapore, but the heart and the stomach always lies in Malaysia. So it's my great privilege to have him here and to kick off our DGBI study day. So I'll not waste any more time. I'll pass the floor over to Kewin. Thanks, Kewin.
To introduce myself first. My name is Kewin. Really thanks, Prof. Lee, to introduce me to come to talk to your team. I think this is a very great effort, especially for sharing. I think it's not that common, to have this kind of small group kind of discussion. I think it helps a lot because it actually make exchanges of knowledges and also your experience and stuff that make it better, not just for me telling you or showing what I know, but also for me to learn from you about your patients. You can see from today that actually a lot of us have seen your own cohort, but it may not be the same as the cohort that I see in Singapore. But for me also, I got a bit of privilege because why? Because I'm also from Malaysia, so I'm also from Penang. So I'm from Penang. I see how Penang is. I see how Singapore, and now I see Kuantan also. And the only thing different is your food is too good already. Wonder how do people eat like slim and eat so much good, like bongkus or whatever. It's really a puzzle. Your out of all the roti, your roti is the most dangerous bone. How can you have to talk like that? It's really not. It's like the level of it's hard to say that it's any healthy. It's definitely worse than a burger. Never mind. But maybe about myself. Like I said, from Penang. From Penang, I went to UK to study med school, and then worked in UK for 1 year. Then I went to Singapore. Mainly because I love my wife. I decided that I'm not going to leave my wife. So Singapore benefited because my wife lived very near Johor Bahru. It's not because I want to leave Malaysia.
Yeah. I met Kewin at London, right?
Yeah. So I've been working there, and actually, I could have been a psychiatrist. Why? Because I wanted to do geriatrics in the beginning, elderly care studies. But when I went to IBS clinic set up by Professor Gui, one of the founder of IBS in Singapore, they're they're all so sad and they're so all suffering. And all of them. By that time, I already run a lot of different clinics, like diabetes clinic, asthma clinic, and all of them are okay. But IBS clinic, my God, it's like this, it's really difficult. We have no drugs, we have no way. The only thing is like whole hand kind of thing. But so I was really affected, and then from then I wanted to do IBS. Lucky or not lucky, because in Singapore, IBS is still under gastroenterology. I should know if you are in Hong Kong and in Japan, actually you may be a psychiatrist that sees IBS. Last time, even right now, a lot of very prominent IBS doctors or researchers are actually psychiatrists. For example, Fukudo. So it just happens that the first thing I ask is, I need to do endoscopy, not the other way around. Not the other way around. Okay, I'll do. So So every year they ask me, you sure you want to do DGBI? You sure you want to do DGBI? That kind of function. Every year during my training year, I say, no, I still want to do this, I still want to do this. Why? I think the same year that we experience all over the world. DGBI is not interesting for a lot of people, because a lot of people don't like to see crying patients. It is not as glamorous as endoscopies and stuff. But I always tell probably we are the one that get car park. Huh? You help your patients. Always say that you help them, they save them, for example, for 10 years, 10 years. There are a lot of patients out there. Huh? I'm not sure. For example, they have not been going out for food for 7 years, or don't go, never left their, like, like, for example, never left Kuantan, whatever, they just cannot leave because whether it's constipation, whether it's diarrhea, they're confined, and then they have to leave their job. Just nothing. The moment you help them, you give them back their life. Huh? 10 years, 20 years, they have been suffering. Huh? So it's definitely something that is the moment you experience it, I can tell that you feel like that there's a one light shining from above, and then it says free car park for you. Yeah, that's a joke, but that's what I want our junior to feel. That's what I want people to feel, because if you don't know how to deal with these group of people, then they are just very difficult cases. They're all complicated cases for a lot of people, and they don't want to see them.
Yep.
And you see patients being pushed. So I really proud that people here that you want to see this very difficult group of people, and you don't like money, really. That's why we're here. We're trying to make your life better, trying to make this feel much more much more, how do I put it, much more interesting, and much more, you feel like you're proud, doing DGBI.
Yeah.
Not just that, like you're like, there's no other thing that they want you to do. Then the last thing you want to say hospital, you do the DGBI. Fortunately, it's a case for a lot of people. We're trying to change that. And that's why I come in. I am trying to really improve DGBI, especially in Asia, for understanding whether there's any difference with the West or not. And I do it, for example, in the association, and Abaje, and then I am on Twitter as well. I'm one of the more prolific like DGBI Twitter on there, and that actually helps a lot if you like this kind of social media thing. It's still Twitter or still X account, and yeah, it's where you get, if you have an opinion, you don't need to publish things, but actually some of your opinion can still go out there and actually make a bit of influence. The first time when Nick Talley took up my social media post and put it on and doing teaching, I felt like, I really should do it more properly. But then after AI, then it didn't. A lot of it is unfortunately not that good anymore because you tend to be lazy. That's how it used to be. If you really read a case, you look at it, you summarize yourself properly. It makes a lot of sense.
A lot.
But now, it's like too lazy. No. So I think people start to find when they use AI, the double-edged swords start to come. You don't enjoy reading, you don't enjoy the result come out, right? You don't feel that proud, like your baby at it. It's like your baby is like, but you're someone. Yeah. So yeah, that's the feeling. I think people are starting to come back and to see how to deal with that kind of AI problem. So
Yeah.
Yep.
So I do agree that X, right, or social media, because personally I also tweet, like what Kewin says, it provide a snippet of the most important things. It's not easy to post a Twitter post. It's not easy. You need to think what are the most important point that I want to deliver to the audience. That is the greatest benefit of X.
Yeah. I must say during COVID it helps me a lot because a lot of time during COVID, so that's why I do a lot of, I actually explain a lot of times, and but it helps by giving you more kind of exposure. People kind of know you and things, So these are some of the things that even as a DGBI people, it's something that not just, you don't just see patients, there are a lot of things, research, obviously you guys want to do research, not even be here. The research, and social media and the things, And the good thing is because the group of people that we affect or change it's a huge group of people. It's not like you're not looking at a rare disease.
Yeah.
You're looking at the disease that can affect your family and immediately can change someone's life. There are so many people that don't know, for example, how to deal with constipation. The moment you help them, it's easy for us. So there are a lot of small things that we do, but actually affect a big group of people. That's why whenever there's a big breakthrough in DGBI, it's always a big news. Huh? Okay, I think I talked a bit too much. Maybe just set with some agenda today. I think today we are talking about some of the topics that I like a lot. Huh? For example, Asian FGID or Asian DGBI, and then how it leads to overlap DGBI that we start to hear more and more nowadays. And also, what's the last topic?
Small
So
fibre neuropathy.
Then go into a rare, then go into this kind of more of a rare kind of diseases, but may not be so rare kind of to end it off for today. So as you can see, the title here, DGBI and Asian distinct phenotypes. This is the batik corak that I'm trying to look for today. You can see that I'm wearing them. I'm not really.
Very nice.
So let's start. Gamma. So the fundamental issue is FGID or DGBI is always, there's lack of reliable biomarkers. Yeah, and then we all rely on symptom-based diagnostic criteria that and also expert opinions. These are the three main problems of FGID. So if you have diabetes, IBD, this won't be there. No, and again, how do you learn? And yes, how do you learn FD? Pattern recognitions, proper and relevant tests, effective treatment. Say what we want. The problem is for the pattern recognition partner, we already have a problem with our FDID. How do you learn how to take a history? How do you learn how to take a history as a medical student? You start to take out the history, first page, chest pain. How do you learn chest pain? From this, MI. From many things. Is it like SOB, neck pain, whatever, PE, all this musculoskeletal. Bloating. Is there anything? Bloating is very different. It becomes like more of I would say a reverse triangle when you talk about history. It's really to include more and more and see what you need to cover because it's multifactorial. Now, nobody teach you how to take a history for multifactoriality. Think about it. We all learn to become an A&E and to solve problems very quickly. And that's the problem with FGID. They don't know how to, a lot of people don't know how to take it. Even from the history parts, you're always trying to see which one. Although right now, don't try to say, visual representativity, I think, but the fact is, it's almost always multifactorial. And you always don't know what it is because there's how many of the mechanism actually have a good predictor.
Yeah.
Almost none, even just for low FODMAP, they're trying to look for that microbiota signal, those kind of things. Almost nothing, The only thing we know is the face look, sad, then it's sad, Otherwise, there's no biomarkers, And that's a problem. Even from the start, you may be wrong, And I would say, when we do our clinics, I like my junior to sit behind me and we see a patient together. Rather than let the junior see the patient themselves and then kind of report to me. Why? Because they always give you a story that you cannot remark anymore. Or this patient comes with this, brought in actually caused by this. It's very logical. And it's very, you're not going to say, what about, because any of them can be different. And you're not going to be able to ask. Because if you follow this kind of logical thing, in the end, it's just management. Everyone knows management. We have so little drugs anyway. So it's actually from that it can be all wrong. So then you may not order the appropriate and relevant tests and no effective treatments. I thought like this because they give me 45 minutes. So it's very, I just, keep talking until they think that I'm like so boring and see what I'm sleeping. Then I'll change my style. I don't normally talk like that. They know actually I talk for 10 minutes, finish already. All right, cheers, then bye, But they have so much time to do. Then, my stuff is very quick one, Then today, like talk show like that. So again, recognitions. Yeah, so after the recognitions, so all this depends on expert, huh? Even today, you look at row 5, why do you think abdominal migraine is in there? Because one of the expert recognize it and make sure that they want it to be there. Huh? So again, a lot of the criteria changes you understand why. If not, that affects your own diagnosis because of someone's opinion. Then say, oh, do I see this also? I see. Yeah. So, but a lot of it, unfortunately, is still from the Western criteria. Because this is what they see. It's not wrong, This is what they see, When you talk about burger, in your mind, in their mind is maybe McDonald's, Burger King, in our mind, Ramly burger, so maybe the same, but the textures are different, So in their mind, so this is what they see. And although they are Asian representative, but the number is actually small. Very hard for it to come out. But recently, when we are making a splash, for example, probably is there, telling them what to do, But yes, a lot of Asians are starting to get into that and then try to make changes so that whatever that we see in Asia also will be considered in the criteria. Yep. And now, just now we say lack of reliable biomarkers. I think a lot of studies are actually in there. A lot of the study that you do actually trying to find out. You and me do actually trying to find out biomarkers. If you read that, actually, obviously, clinically, we all know that there's no biomarkers. Well, the only one probably count uncompressed kind of thing that is super expensive and this is one good examples. Is that calprotectin? Yeah.
So we do send for calprotectin mostly outside labs now.
Yep.
Yeah.
How much?
About, I wouldn't say it's overly expensive, but still need to be a few hundreds now.
How much is the scope? Compared to what's the percentage of the scope and the calprotectin?
Yeah, almost equal. I mean, in the public hospital sense.
What about in US? What is the ratio of the test and the scope?
In US, it's actually much more expensive. Endoscopy like OG, it's very expensive.
Many times? 8 times maybe. Because in Singapore it's the same. Our scope is very expensive. Then it makes sense to do. But in China, in Japan, why do they like to do scope? Because it's so much cheaper. And the thing is not wrong. It's more dangerous, but it gives you a definitive, diagnosis. Chronic DGBI tend to be chronic disease anyway. If you follow the protocol, sooner or later they're going to do it anyway. But it's how fast they do it, and also the price. They don't want to send a calprotectin, they can just do a scope. So a lot of debates normally go into this kind of, whether you should do it, do a scope or not do a scope. Or, for example, a GERD patient, get a scope in China. Why? Because it's so much more faster, cheaper, and then they have higher rate. Although the cancer is one thing, but it's just economical, it's just faster, for them to do this rather than all these biomarkers. So a lot of these biomarkers we can wait, for new one to come in, but it's probably not going to be relevant to us unless someone do it and say, oh, for free for everyone to use. No, if you develop things also, you're going to charge appropriately, right? Yeah, correct.
Yeah, I think it's free this world, and
correct.
if it's free, people also will not want to. They have suspicion.
Correct. So when you look at when we look at for example, any workflow or any consensus, you need to think, who is this for? That's why this also have low income group and high income group now. No. Low resources and high resources kind of consensus coming out from UGO, so the diarrhea, and then then come to the second biggest issue is our ever changing diagnostic criteria. They move here, then they say, they move there a bit, then they move there a bit. Why do you think they keep changing? Why do you, today you say, you must come back at 10 o'clock, then the husband can come back at 12 o'clock. No, 10 o'clock. It's like, the loss of trust and really not. They always say it's based on new evidence and stuff, but actually it's sometimes evidence also that I actually never understand, and unless you understand, I never understand. So for example, the room 2, 3, 4, 5, there's criteria just keep changing, from from what from actually the key one is even though some of the word. So the room 3, let's say, you need to improvement verifications. Then after more study, it shows that don't need to improve. Related can already, Then after that, he changed, for example, they changed the days and changed again from more than 3 days to more than 1 day per week. And then after that, the last but not least is the obviously stool form and they changed the words, abdominal pain, discomfort, cut it out, and then later that they put it back again.
In room 5, yeah.
Yeah.
So
So they just like to keep changing everything, and sometimes they change because of new evidence, sometimes improve sensitivity, sometimes critical relevance, sometimes for a lot of reasons. But most likely because they can call it room 5. Yes. So we have to chase. Let me ask you one thing. What is the prevalence of IBS in Malaysia for the last, let's say, 30 years? Can anyone tell me?
we did a hospital-based study that was about 11%. That was based on room 3. Then after that, room 4, we did a community-based study, just about 5 to 6%. Yeah.
The answer is, see, you really change from one room to another room. We don't know the prevalence. You keep changing the freaking prevalence. How do you know the prevalence? Even for another 50 years, we will not be able to tell people what is the changing. Actually, I thought some of the country that did 2 eyes of form 3. Obviously, they will increase. But they can't. After form 4, then you change another group of criteria. Then your room 3 and the room 5 obviously totally different. Then we'll never know our prevalence. Just keep changing. And that's the problem. Then how do you tell where is this, what is our epidemiology? They totally screw up our epidemiology study. Very hard to do, 10 years or whatever, unless you want to think, like do your own. I always say maybe we should just skip the next one that we do, we should use the room 3 criteria again to look at the previous room, whatever they did at room 3 criteria, because that's the highest, especially for our Asian study, we have that. So that is something to think about actually.
Yeah, there are more data on room 3 than any other criteria.
Right. So that is a good way to say what is the real kind of changes of criteria. That's one thing to think about. And then, funny enough, the worst satisfaction is actually in the group that is undifferentiated functional bowel disorder, which means that they're not in IV and they're not fully in any of the bowel disorder. So if you are not recognized, and that is a problem, and that is the worst group. If you don't belong in any of the bowel disorders, and understandable why, because there's no drugs that's targeting undifferentiated functional bowel disorder. There are drugs for IBS, there are drugs for there's no drug for voting also. But they don't have research that's done for undifferentiated functional bowel disorder. We'll talk a bit about that. So the central questions is come back to us after all this kind of thing. What about Asians with DGBI? Are we similar to the Western court? Hopefully we are, but are we really? And do we see any difference? Why does this matter? Because the diagnosis that they get will determine what kind of treatment that they get and what kind of, and not just the query that they get will also determine what kind of investigation that they get. So you need to know, whether we are the same or not, especially because whether besides just the genes, it's the cultural difference. The breakfast that I eat here is very different from the breakfast I eat in Singapore. Next time I'll just fly here to eat breakfast and then fly back to start my work. But anyway, it's also very different everywhere else. For example, he doesn't eat breakfast, and some breakfasts are very simple, a milk or oatmeal. So you can imagine that is the fuel that different people use to start their day. And also, whether there are really any structural bias and This is again just a bit of the evolutions. I think you don't want to waste time on this anymore. The main difference is obviously some of the friction points, or big difference, the H by the right rate is really higher here. There's a lot more kind of another overlap, and also dielectric trigger, and also gas bomb. To talk a bit about that. And these are some of the cases that tell us that maybe our patient, is what we see. So see in the clinic, for example, the very old Chinese lady and gastric pain after eating, triggered by meals, relieved by passing gas kind of thing. Quite common. You will say, this is a patient that commonly, we commonly see in our clinic. Another one, auntie, severe recurrent belching, bloating, increased flatulence, a lot of gas problem. Then like recurrent upper abdominal pain with heart stools and thing. A lot of our patients, let us say gastritis. For them, there's only one organ here. Which if we really like that, it makes our job very easy. We forgot that there are still colon, transverse, pancreas, there are so many other things. They see things like 2D only. But the moment you see them the 3D part, then people, I'm not sure people here say gastritis or do they say gastritis or?
Yeah. They say gastric.
Gastric, gastric. Gastric. They say gastric not from stomach, not from gastric. Then not boleh. Cannot. So for them is so what about in like Egypt, do you say about gastric also? How do people say about same words or?
Yes, you have other slangs, but say gastric is like nonsense.
What about in Pakistan?
Yeah, same.
Gastric, only gastric.
Yeah, of course they have a different locally terms that may be unique to that population.
The problem is you always tell them that this problem is because of from other parts as in gastric first. That's why the PPI is always on the card. Don't know why, But I think the professor is involved in the prescribing of PPI, So that is a very important exercise. How to take that away from one of people's kind of argument that almost all elderly have PPI. Which shows how successful the drug companies are.
Yeah, how successful PPR.
Yeah. So are we all the same? So one of the first things that we did many years ago, when I was still a young doctor, like Joyce age. I'm still young. And we'd have this Rome Foundation. I think that time probably was still in UK. It's on the other side. On the other side of
the other side.
Yeah. So we come together and set up a Rome Foundation Asian working team. This is what our patient that come in the patient that we must know that maybe from primary and secondary care facilities. Because in Asia, as you guys know, our patients, even university, can still be primary care also. The aim is come together to see whether there's a latent symptom clusters in Asia with FGIDs. Sorry about the words. I didn't want to, I was too lazy to change all the FGIDs to DGBI. Then again, a lot of people still say that DGBI is still not well accepted, and that's the problem. Even the freaking field name also need to change from FGID. I don't know whether after another 10 years, they'll change to something else or change back to FGIDs. Sounds like they'll.
Yeah.
And to very possible differences between Asian symptom cluster and non-cluster patients. So this is a study on 18 years old and older, long-term strain one period, no red flags, those kind of thing, and whether is any patient that's seen in any center just like this center, you see primary care and you see referral, and tertiary care patients. So we actually have used besides the Rome 3 questionnaire, we actually have an enhanced version. Enhanced version just means that we don't actually change the basics. We just add on questions to clarify things. One very interesting stuff that I was discussing, for example, with Joyce this morning is, for example, incontinence. What is the incontinence words for Malay? KK, how do you ask patient incontinence? Is there
there's no actual one term to describe it now. But it was just natural leaking stool. So I think that's what they would usually say, stool leaking.
Leaking, so what, don't worry, saya bayar bagus kembali, ada minggu ini. Much right? Or you so, because I was involved in the Malay translation last time, so I don't remember translating it properly. So this morning was like, wow, quite ashamed. I don't know what the word is. And also because, for example, he actually said that, during the when you look at the data, actually a lot of people pick incontinence, but after you talk to them properly, some of them may not be but but actually incontinence is a very big problem, so we know, but some of them may not be. But in language wise also, then you have to check whether you are doing it properly. So same with this kind of questionnaire. You look at it, you try to make it relevant to Asia, because you want to capture more Asian relevant questions. So it's a bit different now. This EH3Q thing. It's not just a full Rome 3 questionnaire. And then we did a statistical analysis of the main question, although we asked a lot of questions, and did a factor analysis. So the quick thing about factor analysis is just, in simple language, is just try to cluster similar things or similar data together and see whether they come up. And a lot of studies actually try to use that to identify different things. For example, same idea for microbiota that a lot of you are doing here today, and another thing. This is to see whether they are finding any clusters, phenotyping. And previously, even Rome Foundation has used this to look at their own data, Rome 2 and Rome 3. So that's how they use factor analysis to identify in 1990 Whitehead. You've been met Will before?
Yes, so yeah.
Assistant of IBS, and also Kelly, Professor Nick Kelly also use that to look in 1998 to look at whether there's any upper and lower GI symptom grouping. So that's the reason why the Rome criteria. Think about it. They decided to go by anatomical, esophageal, gastroduodenal, bowel, But patients don't just present, oh doctor, I belong to the upper GI kind of patient group. This is a clinic. This is not a clinic. This is the bowel clinic. No, never. But this is how they look at it. They even need to do factor analysis shows that there are distinct upper and lower GI symptoms. How did that come about? Don't know. So 1805 patients, 11 centers, and this is just the numbers, and it shows that these are some of the methodologies or if I go instruments, algorithm, output. I found that this AI thing sometimes doesn't help it. Just make it a bit more, looks good, but very intense. I still need to get a good prompt. But this is already quite good prompt, this one actually is very nice prompt. It's very good. All of you use AI for presentation? Try not to, but what to do? Because it's very difficult to be very get to what you want, and sometimes they are wrong thing. Then doing presentation, then you're like, shh. Because when you're doing this, you're very sleepy. When you're talking, you're very alert. Like, wow. Then correct. So, but for this is the 9 Asian symptom clusters. So it's actually these are the cluster that we found in the Asian populations. The caveat. Asian populations are also very heterogeneous. Correct? We're more heterogeneous than the white, but doesn't matter. This at least we can call it Asians to start with. Maybe next time we can see different kind of thing. But we found that there's a group that keep complaining about clovers and dysphagia. There's one group that keep complaining about chest pain and heartburn. That is more of a up. But there's one group that keep complaining about gas, bloating, flatulence, altogether, and there's the nausea and vomiting groups. Nausea and vomiting is actually quite universal across all MGID, but not but this one also a bit of a vomiting is not though. So nausea and vomiting is a very specific group, but nausea itself is actually just like bloating, cut across almost all symptoms. Then there is one group that complain of abdominal pain with diarrhea, then meal related, because the normal Rome 3 wouldn't have this classification. Why? They don't ask about meal. It's only our group added in question that found actually a lot of patients, like what our own experience tells that they complain after meal or this sort of food, then they have symptoms. Then this group of upper pain and constipation also come up quite prominent, surprisingly. So it's not just your constipation and non-rectal pain, but constipation and the patient that complain with whether it's pain or even most likely actually is bloating or pain or discomfort. Big group. Then the rectal pain and constipation, and then diarrhea and urgency. So you can see this is all not unlike the Rome criteria. There is a lot. This is the 9 Asian symptom clusters. If you prepare yourself for these 9 Asian symptom clusters, essentially you're covering probably about 90% of the people that you're seeing here.
Yeah.
We don't have a lot of all those other kind of, this is the main 9 that we see.
In fact, I think what you say is very important that, for example, gas bloating, nausea. So these are really pan-GIs. They overlap.
Yep.
Meal-related. So in fact, yeah, you are always, when we see patient in the clinic, you must always ask whether the symptom is it meal-related. Again, meal-related is a pan-GI. Only very, very small number of symptoms that are upper GI distinct, like bloaters, chest pain, and anorectal and diarrhea. These are probably a bit more distinct upper and lower GI, but the rest are all very overlap.
Both they just stole my thunder here. Like, this is what I want to say also.
Just
So-
enhancing your.
Yeah, we don't see any classic missteps. That's not what our website is. That's it's just broken up. That and funny enough, just a bit of outside. FD, you always hear they'll talk about FD and gastroparesis. Not us, not in Asia, but this is a very, very common. There's even the talk they asked me to give gastroparesis and functional dysphagia. In my mind, it's very clear. Gastroparesis is gastroparesis. Functional dysphagia is functional dysphagia. But for them, actually there are a lot of because they see a lot more of gastroparesis like symptom. And then they diagnose a lot more called FD. For us, actually, not that much.
Yeah, I think most recently, right, we got a patient down there. Very typical, like gastroparesis symptoms, nausea, and then early satiety, bloating. But we did a motility test, nothing. Doesn't have anything clear signal there. Sounds like probably FD lah, but we still need to do a gastric emptying test. I think one of the problem is that the gastric emptying test is not really much ordered in Asia.
So yes, we have a paper that shows that in Asia or Hong Kong, we don't even think about it. Then we don't even think about it. We don't even order. And even if you order, how many hospital your center actually have a good gastric emptying study test? How many hospitals actually? A lot of hospitals in Asia don't even have that test. Don't even have that. They have sonography. Don't have anything. So how do you actually a lot of time is when they do scopes. A lot of food there maybe but a lot of people don't even think about that. Although that only cover about 30% of possibility that the patient may have gastroparesis. And think about that. What is the highest rate? Which country have the highest rate of diabetic in the whole world?
Wow, Malaysia.
Cheers, man. Then in diabetic and gastroparesis is a huge consortium in one that they did case study. Our gastroenterologists never even thought about gastroparesis as a cause. Think about that. How many times do you get your gastroenterologist refer patient to you and say, please rule out my patient with gastroparesis? Pakistan? Is it? But there is in Europe, right? In Europe and America, and they became huge group. So there's something different about our patients compared to the West. Or cannot just be because we don't do gastric emptying also partly. Also, maybe they just don't present the same way. They just don't complain. Maybe they just all present bloating only without the vomiting part. Because the key symptom when you talk about gastroparesis, is still vomiting, nausea and vomiting itself. But maybe we just present very differently. Don't know. Maybe our esophageal part is very different. Yeah. Next. Lower GI, there's no just functional constipation. Nowadays, it's called chronic constipation.
Yeah, under room 5.
Lucky, our consensus is called chronic constipation. If not, we follow them, we die. Lucky, that one. It's not going to change the whole consensus. But again, how come there's no chronic diarrhea but functional diarrhea still? They don't understand that. We keep to talk them, whenever to talk. Do you understand Malay, right? You know that. See, normally you have to. I can show off my Malay skill, but to this group of people, I can't have to. Only this side. To told me that they keep poking. I keep poking the wrong people about this question. Anyway, yeah, I lost my Malaysian joke side, and I have to throw away all the Malaysian joke side. It's like,
So keep coming.
So yeah. So you have the bowel, the rectal, and really the anomaly, which is the constipation, upper abdominal pain. Why is this important? We'll talk about it, but I want to put it up there first. Why? Because a lot of the patients come with gastritis, dyspepsia. How often do we ask about constipation? Do you ask? Better say you ask. Do you ask? Do you ask? Huh? No, so okay. So don't be so hard. You to ask. You have to ask. Why? See, this tell you that simple reason. This tell you that you ask. How do you ask? How do you ask?
For constipation.
Yeah.
Well, the patient presented to me with he said that I have constipation, so I have
No. This epigastric pain. They never say they have constipation.
And the history is quite long in such person because when they present, they will be presenting and then at the end, I'll come across with something else.
Yep. I totally agree with you. A lot of things to ask. How about you?
I didn't generated the business, so I didn't have a chance to see patient. I used to keep on talking to them, and at the end I get some sort of clue that okay, I should go this.
I tell you what, bowel health is the most important health for the whole of, don't know why, my feeling after 23 years is an expert opinion only. Constipation. Any patients that come in DGBI, you deal with the constipation, you deal with the whole gut. But there's no, this is just me talking, okay? A lot of patients, let's say gastritis, actually I do have you should have a checklist yourself in your heart of all the questions that you need to ask, that you need to think. Mine for sure will have a constipation one. Because if you just ask the question, are you constipated? How many percent will say that? How many percent who are really constipated will say that, who fulfill criteria will say that they're constipated? Correct, 5%. 5%. So imagine all the patients, if you just ask one question and they say 5%, you miss 95% of patients who may be constipated. According to this, this is a big group in Asia. And think about it. So you need to ask at least a few more questions. Why? People with different idea about constipation, frequency, form, those kind of really the 6 one you can ask at least 2 or 3 of them, straining. Then you'll get a bigger, more proper pictures. That is more important than your drug history or whatever history. For DGBI, not asking bowel is a crime. Just think about that. Keep it in your mind. Don't asking about a full GI, especially the constipation question, is a crime. Incontinence, you should actually ask, but part of it, but normally people still forget. But at least the constipation one must get it out.
I have, sort of developed my own practice.
Uh.
When that patient comes to me, say, in upper GI symptom or lower GI symptom. So by the end of when I'm done with the history of the man complaint, I sort of ask few questions that are, pertinent. And I almost ask in every patient about bowel habits. And if I get it good, I tell it.
Yep.
Sleep pattern, I ask
Yep.
about this. And see, if it is a female, so I talk about the menstrual history.
Yep.
So these are sort of questions that almost I ask in every patient. So that helped me a lot while dealing these sort of patients. If they presenting with upper GI symptoms, I try to cover the lower GI symptoms as well in these patients. And if they present with lower GI, I ask about the appetite, the food they are taking, and stuff like that.
My job today is trying to convince you there's no upper GI symptoms or lower GI symptom. It's just one big, GI symptoms. That's why are we thinking in this upper GI symptom, lower GI symptom? Your body don't just have cut, Although there is a diaphragm, so sorry but it's all one big, yeah. But actually it's not. This is one tube. You can do scope if you can long enough, do all the way up and do all the way down. Different sound, but you see, even as senior as yourself, you are still teaching upper GI symptom, lower GI symptom. You cannot. You have to be a whole, because later on we'll talk about overlap. Overlap really eventually it just means that there's no upper or lower. Actually, it's more of that. Thank you, for showing this, because it's a very common issues. 90% of our our resident still think in that way.
True.
And you see, again, it's almost is a triangle, triangle kind of issue. They go from broad to dyspepsia. Oh, what is the next one? Is it ulcer related? Is it? But actually, ours is like this. Our dyspepsia is it? What about lower GI? What about this? What about sleep? What about that? Then you have a whole kind of a pyramid in front of you. Then you try to settle everything. We actually, how often is one drug can solve the problem? That's why we have drugs, we have CBT, we have everything. Try not to go like that. You go like that, which is what all the people, non-surgeon or non-DGBI doctor suffering from when it comes to trying to understand our DGBI patient.
True. Just want to add to what Kewin says. I mean, whenever I go to my clinic, right, I would put up the Bristol stool, chart. Okay, so are you type 1, type 2? So that will give you a sense of what is the bowel. And then I will ask about bloating. Bloating is also a very common question that I always ask. That you have that in your cluster. And meal, is your symptom related to meal? So these are my almost typical question. In fact, that already covered your symptom cluster just now. Yeah. So this screening question is very important for you to look at DGBI. And you're quite right, there's very few distinct symptoms that are really, really upper and really, really low. Very few.
Another thing that I think some of us do, or not me, but you have your questionnaire or waiting room questionnaire, we call that now. That at least you come in, you won't be affected by the patient. Sometimes but they will actually feel a lot of things. So it helps also, if you have time or if you have the setup, or even next time AI, this kind of thing, help us even before they come in and give you everything. Because I think what is the most important thing in DGBI care that we are lacking? Money, time. Time, no? We have enough time. You give somebody, some amount of time, meaning that you're gonna take some from other people. You're stealing from others to give you a Robin Hood like that. You take from one and give it. Hey, 1 minute, don't sit down. You're normal. But someone would need more time. We cannot afford to give sometimes. Even if you want. Then even if you want to give, sometimes you become very upset yourself, So yeah, that's the problem, how to take those kind of things. And then but I believe that AI will hopefully help us with that part. Just what I heard Elon Musk say, doctors are useless after 3 years, but not us, not us. We try not to program that into the AI part, then we're still good. They say they can do surgery better than anyone.
Yeah.
Sorry, the surgeon. Anyway, so whether this is uniquely Asian, whatever, I don't know, but at least this is what they are not reported, and usually we see a lot, and it's very important in at least in our field. And this was studied quite long ago, 2016, about 10 years ago. So yeah, and they are not, to say that they are very low prevalence and rare disease, actually quite common. So you need to know about them, and that's a bit more about the upper abdominal pain and constipations. If you remember your neuro and your anatomy, and when the gut twists, but you don't know how they twist.
Be a torsion.
Yeah. No, sorry, not the torsion, but the neuroanatomy during development. So our thing twist, So actually, only the surface part. We always say that only the surface part give you, your appendicitis or something. But actually, for neural gastro, you should actually forget about this thing. This is only good for A&E. Because whatever patient have pain, it doesn't really correlate at all. As you grow older, that one that you're trying to learn as a medical student is totally a waste of your time. Doesn't mean anything. And a lot of people done study and shows that actually a lot of people experience constipation pain at different places. It doesn't mean that pain here that must be terrible color. No. So there are people who put a balloon into their rectum, and people do feel pain at different sites. Have you all have a balloon put up your rectum yet? It's a very nice experience. So go and try it. Then you then why? You put that into the patient's balloon rectum all the time anyway. It's just a reverse. It's a reverse.
Yeah.
Yeah. I did that as a medical officer was doing when I was young. I said, what is balloon expulsion? How do I explain to the patient? Then I put one up and I feel very sorry for myself. So I got ideas to try it out. But anyway, yeah, balloon expulsion is actually so it's the same, So it's just the pain, then you can say the pain actually felt more up here.
Just want to add to that. One of my friend, a close friend of mine, he used to say that the best time in his day is when he sit down at the toilet and pass motion. Yeah. Because he will say that when you pass motion, there's they have a sensation. It's a very pleasant sensation, according to him.
Okay. A lot of our patients that go for colonoscopy, what is the thing that they hate the most? The whole process. It's the drinking of the pee. I'm not sure about the patient. The bowel prep part is the drinking of the patient. But strangely, the most, what we call the shock part, the happiest part, is when everything is out. It's the same thing as when you pass motion. The blissfulness, blissful. Think about it, But another thing about constipation that I want you to think about, constipations, what is constipation? Is it a symptom? Simply put, constipation is a lot of stool in your body that you cannot. Does it need to be a lot of stool? We know that there are normal transit. What is somebody? You say, but you're normal. What? Totally cannot carry any stool at all. Their study, actually, the study, even though it's very good, they let the patient keep passing motion. The patient actually relieved. Just like see gone abdominal pain gone. So in your mind, there's no such thing as normal, and then you reach. There are people who just cannot have any stool. If you have this in mind, this is very strong kind of ideas. There are people who really cannot have any stool in their body. It's the same. That's why they can't even carry any gas. Bloating a bit also, no gas, bloating also. They can't tolerate it. That's why visceral hypersensitivity come in. Some people just cannot carry stool. That's why after they do the poop or they go for the colonoscopy, they feel so good.
Yeah, they feel much better.
But the effect only lasts for very short. Because the moment they finish, they start to collect poo again.
Yeah.
this is
We're just like a plumber lah. You just imagine the GI tract is like a pipe. If your pipe is blocked, you feel everything is gone haywire, right? Water is not running and things like that. But once you relieve that blockage, right, all the pipe will goes on again. So for us, we are like the plumber,
The other way now,
professional plumber.
how do you know? There might be people who keep their stool in their body for a few months. Now I can see the doubt in your eyes. I may be able to show you some pictures later. Can you imagine keeping stool in your body for a few months? But they don't feel it. They can don't, some of them obviously a lot of them feel pain. But there are people also keep a lot of stool that don't complain. That's why a lot of elderly, or even mental challenged patients, they come to the hospital, you need to be very careful. Their stool may be up to here already. Because they don't, a lot of them are whatever, they don't feel it. So, there are people with a bit of stool may feel it. There are people with a lot of freaking stool, or no stool, feel it, food may actually feel nothing. So it's a very, it's something to think about. It's not so simple when it comes to your pool. I think the speed is a bit too low. Too fast, too quick. I think I need to make it faster a bit.
Quicken a little bit. Yeah.
Any questions before we continue? Hope that I'm challenging your mind rather than putting pool in your mind. So early satiation clusters and so let's talk about that. So what is the repercussions after we say, hey, how come in Asia we found 9 clusters only, not your Rome, so many clusters? So gut got these people, Jared Hoffman and Nick Talley, two gods of DGBI, who say in consistency they take their chances and they try to whack the Rome people for very long already. These are all recorded, right? I've died already, I finished. Whether FGID is Rome burning, damn good at the right thing. So they says that our data is a fire, it's an opportunity to rewrite the building codes of the transaction, I think opportunity. So they actually did their own another Australian and said that actually is again, doesn't really go very close with Rome. So this is sort of started a bit of a hey, something is not right about just the Rome cluster. Although people have been talking about that for the longest time. This time this study shows that really there's something different between the Asian cluster. But we don't know why, whether it's really different or not, or whether it's just a methodology. This is just, but at least there's a study that shows that then boom. This is Rome 3. Just now was all Rome 3, The study was done during Rome 3 era, then come up with Rome 4. They did a study again using factor analysis to show that, and factor analysis, the die still want to say. Factor analysis define distinct upper and lower GI symptom group compatible with Rome 4 criterion in a population-based study. So, they still want to hold on to the distinct upper and lower. These are the paper, they say that there were 8 factors, they use factor analysis to show that there were distinct upper and lower GI symptoms. And this is the model that they use. They show that there are, if you look at this, Globus, heartburn. This is the real one. Exploratory model is the real one. Confirmed model is those that they put diagnosis, heartburn, upper GI symptom, IBS. These are really the by computer. No human. Confirmatory is really but human. So after that, 8 symptom classes are for exploratory model. So I saw this, then I thought, hold on a minute, your exploratory model look very much like my Asian FGID clusters. So what they have, for example, in the exploratory model is that heartburn is very similar. It's very difficult. Just trust me, that it's quite similar. The chest pain, heartburn grouped together, like how our Asian group together. So our agent actually is actually very close to the room 4 exploratory model. The chest pain, heartburn, it's not the one the confirmed model they thought. So yeah, so you can't see this, but I freaking wrote another letter. I wrote a letter to the editor and said that, oh, I mean, yours closely resemble my symptom clusters. So trying to say that your thing confirmed that our thing is probably the symptom clusters that people actually see more.
So did they reply back your
Yeah. I'm not going to show that, right? But I'm going to tell that you think that things are not right. You can actually write, a letter, to go and fight them. Yeah. Then irritate them. Yeah. Irritate them. To irritate them, then they will take more attention to what we are talking about. Really is what Prof. Lee just now was saying. There are a lot more overlap than there is non-overlap. Not just upper and lower, but the combinations of upper and lower. This is our own study again from a Rome 3 criteria, just done a big study, shows that overlap, almost half of IBS have overlap. Almost 82% of functional dyspepsia don't just have functional dyspepsia, overlap. Unspecified overlap, belching definitely have overlap. So our own data, shows that overlap is very important. And the distinct thing that we found just now, the thing that is actually, what all of it is actually overlap. They're all overlap kind of thing. That's why FD is blend inside there. Yeah. So what that is addition. So we managed to say, oh, not so similar. How is the Ultraman? Maybe And yeah, this is just now the studies also did that and shows that there were overlap, what are maybe different. We will talk more about the overlap thing the overlap thing later, but because afternoon we still have overlap sessions. But think about it, ultimately, these are all clinical presentations. If you don't look at you don't look at the real count group, then when you do your precisions, you do your diagnosis, you do your phenotyping, you'll all be wrong. So you need to look at the right group. The last time when they give you IBS, it's different. It's almost like you give you a group of people with diabetic and thyroid disease put together and try to ask you what is this group of people, try to treat them. You cannot. You need to treat them with diabetic medicine and thyroid medicine at the same time. But what we have now is actually a group of diabetic patients and thyroid problem, both hypothyroid or hypothyroid, but people are treating them with just diabetic medicine. It won't work. Let me see, because we cut. Yep. So this morning first session take a bit longer. I hope this is your cup of tea. If not, then tell me what kind of tea you like. I'll change the tea. Yeah. Any questions?
Yeah, thank you, Kewin. I think this is a very good first lecture to start the day. Definitely in my practice, similarly, you see a lot of overlapping patients. So I think the message here is really to think beyond just distinct upper, lower, but really focus on how do we take much more pan GI kind of symptoms. So eventually DGBI is really a pan GI condition. Any questions to Kewin?
Dr. Kewin, can you hear me?
Yes.
Is Ami here? Hi.
Hi.
Sorry. I listened to your talk the whole way, so I'm not going anywhere. So just wondering, you gave a very good case example that there were 3 cases, right? Most of them are gas related, and we found a lot of this in our Asian population. So how do you approach this? Because whenever I had somebody with bloating, gas, right, the only thing I can think of is SIBO, visceral hypersensitivity, and nothing else. And the only thing I can offer is probably breast test, rifaximin, empirical if I don't have breast test, and then nothing more than that lah. Instead, do you have any specific framework to approach these gas related complaints? Dr. Kewin?
Where is it?
He's now in Seremban.
In Seremban,
I'm based in Seremban. I'm going to HKL tomorrow, so that's why I'm not there. I'm so
You
sorry.
ask-
I'm changing place.
You ask HKL to invite me. I tell you.
Oh, can, Prof,
No, no, no,
Prof,
no, no.
can.
Okay.
We'll get a food crawl in KL going.
We're going to I'm going to KL with doing our a bit of October. We have our Asia Pacific neurogastro functional course. Do join us. Anyway,
That's at the end of the year, right? Somewhere in November, right? Yeah,
October.
I'll be there.
Yeah, yeah. So a lot of us will be there. So probably also be there.
October, yeah, October, yeah.
Yeah. Come to this
Yeah,
question.
I'll be there.
So the big one is bloating is a very big topic. I a lot of patients complain about bloating. Obviously, they come with flatulence. We call all of them gas, the gas symptoms. Again, just now I think we touched a bit about that. If you ask the bloating questions, like how you do, for example, the reverse triangle, how you do like chest pain history, those kind of things, it then doesn't work. Why? Because it's not just one reason. No, I don't need to tell you about the pathophysiology of bloating. Just now, we also talk about different like SIBO, other thing. I can tell about a bit about my approach. My approach is actually always tell patients there are only 4 reasons. Okay, 4 reasons for bloating. Okay, always start from constipation first. The most common reason is constipation, although diarrhea also can. It's actually bowel. The next one, food. Food does give a bit of problem when it comes to bloating. Food. The second one is, I know it's not very popular here, but gut microbiota. A lot of the dysbiosis, because of that. The fourth one is here. It's the mind. So I tackle them not one by one. I tackle them together. So I tell them to follow. I'll check their diet first, whether they have a lot of high fat and high fat diet. The problem is our population actually very low, already very low. Common diet. I'm not sure about Kota Baru or is your FODMAP base lay? If you look at your base level of FODMAP.
Actually, we do eat a lot of FODMAPs in Kota Baru. Although we don't have data, but I think last time we did some study with where we look at the low FODMAP diet. So it does work. If you look at our Kelantan-based diet, right?
I don't just look at it.
Yeah, really experience it, right?
To my stomach and digest it.
Yeah, then you realize that we do.
So one of it is really for me. I actually go through with them. Surprisingly, a lot of people don't know about vegetable as a source of FODMAP also. And also, so I go through a bit of food thing and do a not gentle FODMAP. Mine is super gentle until don't know what FODMAP. Then then third one, I do give them probiotics. And then I tell them that, if these 3 things, if you manage to settle these 3 areas and you still have problem, I want you to go back and think about, like your sleep, your stress, when how is it affecting you? Normally, those that is stress or whatever, they'll tell you that you're in stress or whatever anyway. And this will cover about 90% of your problem. If not, then I'll send for SIBO, I'll send for other tests. But I know that it's normally my part that's most important already. SIBO actually is just a replacement of the probiotic. It's just cheaper. So yes, for me, it's really I go through this and I treat them like a triangle, a broad-based management myself. I'm not sure about Prof. Lee.
Yeah, I mean, bloating is definitely a very common symptom. We have last time did a survey sent out through Facebook. 50% of Malaysians reported they are bloating at some point of their time, and many attribute to stress and diet. So if you are able to tackle this so-called stress or psychology, like what you mentioned, and the diet, you help a lot for the Malaysians. So always ask about those factors when you are approaching people with bloating and gas. I agree with, in fact, whatever Kewin mentioned, I also did the same to my patients. They do respond quite well to some of my patients. They do actually respond to probiotics.
And obviously there are other things that, for example, drugs like this spasmodic or those kind of thing. So, use them wisely. It does help the patients. But depending on how you use it, so a lot of this spasmodic, I like to use it even for them to predict even before food. It's very hard to stop something. So a lot of patients just use domperidone, right, or those other things. But it's very hard to stop something when it's already happened. So sometimes before like good food or before like buffet, then you ask them to take some of the medicine first. That's how I do it. Before it happens. Yeah.
Say that for that is a very good section.
No. I know that here there's not many type. For example, you have
BioFlow,
which I took before, and they give me then what else do you have?
So we also have Scalp Pro here, Hex Bio. These are the few that are available, but there's a lot outside. We have BioGaia. We have all type of probiotic on the shelf that you may not even heard of or know.
So for me, my practice, my hospital, we have about 6 probiotics for us to give out. The only one that is you can give out from the hospital is called ProGuard, although that one don't have many evidence. But patients also buy over the counter in our pharmacies. The most popular one is Delsimon formulations. It's called Vivomix here. Delsimon, VSL3, Delsimon simulation. It's one of the one with more, at least the combination with more evidence. Other than that, it's Alpharex or One Pro. These are the Bifido different kind of group actually. So Bifido probably is the group that I'll go for, but I do find that patients respond better with multi-strain rather than the single one right now. But really, how many type of antihypertensions are there? How many? Yeah. Probiotics are all different. Doesn't mean that use one, you cannot, because we don't even know what we are. And to be honest, for example, America say no to probiotics, Europe say yes to probiotics, British say yes. Asia actually will say yes. Because a lot of the doctors in Europe are the one that create the probiotic anyway. So it's always biased, and yes. So when we talk about probiotics, they're all different. Try not to say that they do one group. Ask my patient to stop their probiotic and use mine. Use what I prescribe. Because we'll talk about it later. But because those that you give out as a doctor is very different from those that they buy over the counter also. Because the commission, there's no commission. But it's really, make sure that the outside one can be really anything. As I said, may have nothing that helps. So it's better to give those that works and then maybe change.
Yeah. So I would say that build your experience on the probiotic that you use and know the probiotic, what are the studies that have been done, what are the data out there, and on what condition. So if you know that, build on the experience and then see how the patient responds.
Yeah. I've been using probiotic for many years, and I personally see a paradigm shift. So it's very difficult to see because the problem is there are too many research that is actually very poor quality. So it's difficult when you put together, then everything is poor quality anyway. So how many years does it take to help? But as a own physicians or the evidence is an expert opinion, right? My opinion is user, because I personally see a difference in how patients respond to the drugs.
Yeah. Yeah. Any other questions? If not, then we can start with the case discussion next. Can get the coffee also. Those who have already ordered at the back.
Okay, all right. Let's go for the
More people here, we just go
Yes.
round again.
Maybe just maybe round of introduction for the maybe starting from you want to from your yes, just a quick one, just to say where your name and what you are doing.
one professor and doctor. I'm Ahmad Sandu. I met that year in Provoking.
Hi everyone, my name is Asro. I am a PhD student under the guidance of Prof. I'm currently in my final years and I hope to finish soon.
Yeah. So he's working on the functional dyspepsia using multiple markers, imaging, and then pathology, endoscopy. So he's a FD guy.
I know because like when I registered to study, it's like for the
AI.
of AI.
Yeah.
So what do you do for?
I guess from
So it is
A
important here.
important year.
yeah.
Vital
Ini
year.
kali lah. Ini kali lah.
But I am speaking Malay. Malay is fine.
Yes. Di Sabahan.
I'm Sabah. Yeah. Malay.
Yeah.
Malay is fine.
Yeah. Di Sabah Sarawak.
Yang nak order boleh tak
Yes,
order.
that's good. Yes.
Wow. Yeah, so like 2 flights away from Batam.
My friend is from Taiwan.
Oh, really?
It does like lab check business in Taiwan. Obviously, always.
Is it your? Do you mean there's a? He is also in the food industry. Okay.
Investigates fibrage and Asian diets, what is the microbiome on the second nuggets, and understand the influence environment.
Oh, very nice, very nice. What kind of traditional diet?
Boundary.
Then
Malay concept, Chinese concept.
yes, Malay also have a director of Asian diet. So the
Never been a diet for Indians.
Yeah, why not? Right. So maybe after this, you can show the menu that we developed.
How before the child was born, what they eat and stuff. And it's not micronutrients. It's affect development of IBS. Yeah. So, but this association for me, quite cute. I still do you. There's no research on UNDC.
Something.
Okay.
Only the good part.
Only the good part, Kewin, only the good part. Okay, all right.
Joash, now I think all of us know Joash.
Yeah.
So let's see what kind of case that you can share.
All right. Okay. I'm Joash, and I'm going to share one of the patients that I was looking after back in my time in Alostar and Sultanah Bahia, in my previous center before joining Professor Lee here in USM. And I'd like to introduce you to Madam S, who's this really, really lovely, really wonderful 63 years old lady who was struggling with osteoarthritis and had a history of COVID in 2022. In terms of the COVID, yeah. Okay. I'll change the name. What's the other name? SA. Okay. Bye. So she had COVID in 2022, and then later on, in 2024, she had adhesive capsulitis, where she was diagnosed by our arthro team with having left supraspinatus tendonitis, and SASD. It's a something about the shoulder joint, bursitis. And when they further examined her, they found that she had positive impingement, and she was undergoing physiotherapy. And because of the complex pain that she was having, she was co-managed by our colleagues, in APS, and she was on gabapentin, and she was also on paracetamol. In terms of a bit about her background, she's a very highly accomplished lady, a mother of three, and she was previously a professor of psychology in education at a public university around my region. Very, very wonderful family. The husband is a state economic advisor, also under my care, which I'm looking after him for a very stable, very chronic compensated liver cirrhosis. And one of his daughter, whom I've also had the honor of working with, is a senior pharmacist in my hospital. And as you expect with this lady, her profile, she is a non-smoker, non-alcohol, very financially stable, and a very pious lady. So in her previous work, in her vocation, she did a lot of reading, a lot of publication on top of her usual academic teaching. And then now that she is retired, she spends a lot of time in the mosque, doing the Quran, religious studies, mengaji, and also she spends a lot of time teaching students in the mosque. So it all started in September 2025 when I was looking after the husband, telling him, going through his Child-Pugh score, going through his bloods, making sure that he's not exciting, not encephalopathic. And the husband decided to ask me, by the way, can you see my wife? To the chagrin of the wife nearly lost it at the spot. He's like, no, don't, I'm fine. So what happens is that the reason why he asked me to see the wife was because he told me that my wife has not been eating very well. That was it. Makan tak bagus, makan tak lalu. That's all, right? For the last 2 to 3 years. And so managed to get her to sit down on the chair, sit on the hot seat eventually, and then ask her very gently, do a bit of probing. And in terms of the appetite problem, it was because she was having very early satiety. Eat a little bit, makan sikit-sikit kenyang. After a little bit of meals, she gets very full. And then she started to lose weight. Now, because she lost weight, then the daughters were a bit worried, the husband was a bit worried. Before I went into the further investigation that has already been done, I also found out she was constipated. Although that was not a main complaint, but I found out, but in very specific questioning, I managed to find out that she was actually having a Bristol 1-2 stool, even though she was having a normal frequency. Although she denies manual evacuation or straining, but she does experience occasional sensation of incomplete evacuation. And I think the most important thing that I specifically asked her, because I was working with Kewin and the Singapore team on a constipation project, one of the very important things that I now ask with constipation is that after you pass your motion, do your other symptoms improve? Does your appetite improve after you pass motion? And of which she thought, she spent a bit of time thinking, and she felt, no, not really. So no significant association, therefore. Now in 2024, because of all these symptoms, I think for the majority of doctors, we could identify that there's red flags, right? There's a loss of weight, there's loss of appetite, and then there is also the bowel habit. So she already went for the scopes. Our surgical colleagues performed a scope for her almost 16 months ago, and it was a normal upper endoscopy, whereas a lower endoscopy, suboptimal bowel prep, but they didn't find anything specific. And because of that, she was discharged from the surgical clinics with the usual advice of high fiber diet and adequate fluids, exercise a little bit more. Now, She is a very cheerful person. She's very pleasant, very lovely, speaks very, very well, but of course very unhappy because she was forced to sit down by the husband. It was a very unremarkable clinical examination, no palpable lymph nodes, no pain elicited. And that's the most important thing. There was no pain on complaint and no pain on examination. And eventually I asked her, how can I help you? She said, I'm fine. I really don't want to take up your time. I just want to focus on my husband. At least she agreed to undergo some questionnaires. So in my clinic, I do 2 sets of questionnaires with my patients. That time I did 2 sets of questions with my patients. And one is the Australian SIGIS questionnaire. It's a structured assessment of the GI symptoms, which I find very useful to help me make sure that I do not miss anything. And the SIGIS questionnaire also consists of open-ended questions, question 23, question 24, which is an open-ended question. Tell me, what are you most worried about? And the second question, what are you next most worried about with regards of your health? So in terms of the SIGIS questionnaire, I found that the high domain scores was in the epigastric upper, right? And the nausea and vomiting domains. And what was most severe, what was most striking in terms of thorough, right, was no appetite. She had a bit of regurgitation, she had some constipation, she had satiety, epigastric pain, but she felt that it was more related to the discomfort of a bit of discomfort. And then in terms of the FFSG score, which is the frequency and severity symptom of GERD, this is the Japanese by our Japanese counterparts. She scored 8, but of which it is a dyspepsia component which is scoring higher. So my train of thought back then was that I was dealing with perhaps two distinct problems. First being functional dyspepsia, where I identified that this is likely going to be postprandial, right? Very, very full, very fast, eat a little bit, very full, very quickly. And there was a component of chronic constipation because she was having symptoms of the sensation of incomplete evacuation. Am I dealing with a defecation dyssynergia? And also the next question that I was thinking, is my constipation contributing to the upper GI symptoms? Okay, sorry, this one before I heard your lecture, so that's why I still use upper GI symptoms. Okay, forgive. Okay, so considering at the point of time, considering that the lower scope was suboptimal bowel prep, I felt that at least I wanted to make sure that we have a good bowel prep, a good Boston bowel preparation score before we clear her and say, yeah, there's nothing wrong with your lower GI. And then finally, one of my other differential is that of SIBO. So spend some time talking to her, explaining the story to her, telling her my strategy. Upfront, I did tell her that, hey, your symptom is very, very, it's real, you know, what you're going through is real. So gave her a positive diagnosis that this is what I'm thinking. I think there is a postprandial distress syndrome going on over here. So, but at the same time, I want to make sure that I don't miss anything lower GI, considering that you had these symptoms. Your scope previously was done by very good people, but it was incomplete. So can I do it again? At the point of time when I saw her in September, not very agreeable. She really wanted to spend time looking after the old man. So a lot of reassurance given. I told her, take your time. Don't rush it. Let's not rush it. I want to see you again. At least give me the chance to see you again. So finally, the WhatsApp came through by the daughter. The daughter WhatsApp me, hey, good news. Mom agrees to see you. I was like, yeah, man, okay lah. Let's see you. So I got her in and then she did a blood test. She was agreeable to do the blood test. Biochemically, profile was normal. I also did tumor markers just to, sometimes we just do tumor markers just to make sure that we don't miss anything. That too was normal. And she was agreeable for the colonoscopy. The good thing was that we didn't find anything significant. Just a very benign cecal polyp, which I could remove by forced polypectomy, confirmed on HPE. And before I did the colonoscopy for her, I did a digital rectal examination for her too, where I went through the 3 steps. So what is the resting baseline, your simulated squeeze, your simulated defecation. And fortunately, nothing that jumped out from the simulated squeeze or the simulated defecation. It was largely normal. And so with that, I commenced her on osmotic laxative, I commenced her on a stimulant, and I also commenced her on a prokinetic of etopride. And at the back of my mind, one thing that I used to do, one thing that I still do is that at least I want to have some radiological imaging, because don't forget that this lady is not a young lady who has significant loss of weight. Even if I remove upper and lower scopes already, it doesn't mean that there's nothing intra-abdominal. So I subjected her to a CT-TAP, and the CT-TAP was actually normal. So saw her back again after 3 months in February 2026 with the lactulose, with the bisacodyl. Her constipation improved. So she was able to report to me an improved Bristol score. There was a once a day motion, but then the appetite still remains poor. So even though there was improvement in the constipation component was more settled, but I didn't find any improvement in the appetite. In terms of the SIGIS score, the SIGIS score actually worsened to 34, and the FSSG score actually jumped to 21. So this was when, so in front of me, I already have a serial scoring system, and the scoring shows me that, hey, things are not getting better, even if the constipation has improved. So it's when I told her that, hey, you know, there's this really good facility in USM in Kubang, Korean, that I would like you to go to. They can do breath tests, they can do anorectal manometry, and it's a very good thing. Then I can be able to get a better diagnosis, we're able to treat you better. Very not agreeable, not too keen to make the travel, keen for empirical therapy. And at the point of time, I also started talking to her about neuromodulators, that, hey, look, this is a very real symptom. If we can give you an agent for your brain gut, then you may be able to experience some improvement. So she was very kind, but eventually she looked at me, gave me a small little smile. You don't think I'm crazy, do you? Said, no, obviously not. You are a professor of psychology. Why would I want to think you're crazy? So wanted some time to think about neuromodulators. So I commenced on augmentin 625 mg BD, antibiotic broad spectrum, started her on PPI on pantoprazole. And the reason I started her on pantoprazole is because my FSSG score, remember that we have a frequency of symptom and severity of GERD, and that score jumped. And there was an acid component to it too, which I will show you later in a table. So, and I gave her an early appointment to see her back in 2 months to make sure that things were actually more settled. So revising back my differentials based on my normal scope, based on my reasonably normal scope and a reasonably normal CT-TAP, is that I still think that I was dealing with a PDS. And the chronic constipation may still have a defecation dyssynergia component because I don't have a manometry to prove it. But at least endoscopically, radiologically, I'm not dealing with a large malignancy. Reassurance done. I was able to look her in the eye and tell her, look, this chapter of the life, we can move on already. And of course, I started her empirically on SIBO treatment. Now, in early April 2026, also after her PPI was given, after augmentin was given, symptoms were same, there was no significant improvement. And finally, after great consideration, she did her reading. I told her initially about what I wanted to start her on. She was agreeable. Finally, she was agreeable to commence, and I started her on low dose of mirtazapine, which is our, what agent is that? NASSA. And I also started her on lactulose, and I kept her on lactulose, which is a lower dose, etopride, and also pantoprazole. APS medication was continued during this period of time. There was no changes to it. Now, 3 weeks after she was started on the treatment, I got a WhatsApp. I got one of those heart-stopping WhatsApps from the daughter. Hey, my mother stopped taking the mirtazapine. Hope you don't mind. My mother stopped taking the mirtazapine because she got oral ulcers. Okay. Now, as I was thinking to myself, neuromodulators and oral ulcers is quite a long stretch. Until she being a pharmacist, right? She being a pharmacist with great access to all the drug information, she sent me this snapshot down here, which shows that some SNRIs can, with neuromodulators, NASSAs can be associated with weakened immune system, right? May cause a decrease in white blood cells, fever, basically immunosuppression. And my heart started to skip a beat. It's like, oh man, what have I done? So I want to see your mother tomorrow. So that was just like, I wanted to see her tomorrow. She was still in KL. She was fine. The daughter was not too worried about the condition. So I said, I want to see mom in the nearest possible time. If she doesn't improve, please go to the nearest center. So the mom came back to see me. And this was the picture that we were able to take of the oral ulcer. A very aphthous, maybe around like 2 to 3 millimeters, 2 to 3 millimeters in size. And it was already showing signs that it was starting to heal. So of course we stopped the medication, did all the full workup for the bloods, which did not show any immunosuppression. CRP was not high. And then my OMFS colleagues met her and said that, no, it actually is a healing ulcer. It looks very aphthous, looks very benign. And also there is no other signs of infection or inflammation anywhere else. So reassess her in 2 weeks. Later on, I found out that actually in this period of time, the family members actually were going through a bout of URTI. I started with the grandchildren. She was looking after the grandchildren. They were not feeling very well. Then the husband had a URTI symptom. She also had a URTI symptom. So asked her, but then since she was already in my clinic already before the appointment day, I asked her, can you tell me about your symptoms? How are your symptoms? And she said about it and she felt, hey, actually my appetite improved. My appetite improved, my weight did improve. And when I ran the SEGIS and the FSSG questionnaires again, the scores dropped by more than 20%, right? Remember earlier our SEGIS score was 34, it's now 20. The FSSG, slight improvement. So no rush, not going to rush this kind of patients into starting back her mirtazapine. So I told her, take your time. Once you're fully recovered, once you're confident, we can definitely revisit starting it again. And in terms of the sleep, she wanted to make it a point that she was not having problem with sleeping. For some reason, she just wanted to make it no, I have no problem sleeping. I don't need a medication to help me sleep. Okay, so that's that. So eventually, so over the last 2 months before I moved here to USM, I saw her a couple of times with the husband, without the husband. and the ulcer has healed. The ulcer has fully healed. She's happy already. But in terms of mirtazapine, when she started taking the mirtazapine again at 7.5, but then she felt that even though my appetite and my weight did improve, she cannot tolerate the effect of the drowsiness. So remember, this is a professor who enjoys studying, who enjoys her time in the mosque to mengkaji. And she find that that routine of hers was very markedly affected. She cannot focus. She was very drowsy. She felt like a zombie. Her friends in the mosque were realizing that. She go back home. She has to sleep, which for her is a very important thing. She cannot accept sleeping in the morning. She wants to be highly productive. She wants to continue being able to look at the grandchildren, doing the housework, making sure the husband doesn't do anything funny. So without the mirtazapine, with a lowest weight of 33 kg, her weight now is fluctuating between 35 to 36. Appetite is the same, the satiety seems to be under control, but she's now on lactulose, PRN dose, and only on etopride. What is her journey? So if I were to put out the graph in terms of this questionnaire, and why I like the questionnaire is because for a resource limited center like mine, I rely on the questionnaire to make sure that I'm not going off tangent, that my treatment is not moving in the entirely wrong direction. One. Number two, it also gives me an opportunity to make sure that I do not miss any other symptoms. So if we look at the September journey, we have a very high FSSG score, SAGE score. The score actually worsened in 34. And the components that jumps out is the epigastric component and the nausea vomiting component. We find that there is some improvement in the overall SAGE score after we was able to start her on the mirtazapine from a 28 score down to 20. There's improvement in the epigastric domain, and more importantly, in the nausea and vomiting domain, there's improvement. So if let's say I would, at the very end of this, as I was reflecting on this case, I felt that the differentials was PDS, which responded well to mirtazapine, but then it was poorly tolerated to her. There was chronic constipation, which responded to osmotic laxatives, even if the constipation did not, even though the constipation improved, it didn't kind of improve the functional dyspepsia components. And the SIBO was unfortunately unproven, and also adjunctively, I probably wouldn't say SIBO, considering that it didn't respond to the antibiotics. So in my last appointment, and also recently, I texted the doctor to let her know, hey, I'm going to talk about Mom's case with Prof. Lee and Prof. Kewin. Prof. Kewin came all the way from Singapore, going to talk about it. And then I told the daughter, like, ask Mom lah. Ask Mom, does she have any questions for these two professors? And they say that, and she, a very, very sweet lady. So, okay, so after we're not able to consume my mirtazapine, blah, 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 the same thing. And the specific question that she wanted to ask the professors is that she's being worried about being dependent on lactulose, and she don't consider constipation because she poos every day, which is very common concepts, very common questions that our patients will raise to us. So when I look after DGBI now, I reflect, as I was preparing this case, I reflected on the care that I provided to this patient. And the truth is that there was a lot of regrets. It's like, I should have done so many things better, right? For example, now that I look at lactulose, I should have considered, why didn't I consider Folex, right? Why didn't I consider Macrogol? Because it was going to have so much lesser symptoms in terms of bloating. And the reason why I didn't consider Macrogol is because that time I wasn't fully exposed to alternatives of this kind of stool softness. And of course, I should have explored diet. Right? I should have explored diet. Not even a single detail about diet came in. And the honest truth, the brutal truth is because I did not explore it. Other things that I could have done in my center was I probably could have done a balloon expulsion test. I could have done a colonic transit to prove that I'm not dealing with a slow transit or defecation dyssynergia. We can actually pick up defecation dyssynergia on SIT-SMART test. And now as I think about it, I should have done it. And more importantly, I felt that maybe if her condition was improving, not improving, right? And maybe I could have re-explored talking to her about coming to USM for further investigations. So really the questions for our two experts here, for our two professors, is that we want to explore mirtazapine and the sedative effect, right? We know that there are collections of small studies, case reports that say that when you mirtazapine low dose sedative, high dose not less sedative, paradoxically, would you have started mirtazapine at 15 mg, right? This patient already stopped 7.5 because she beta han. Would you have hit harder at 15 mg, or would you have switched out her agents? In terms of the immunosuppression, have you all encountered immunosuppression with neuromodulators? And complex plane, I deliberately left the question open because I think we can even have a chat about this, her complex plane. She was on gabapentin. There is also gabapentin, there's PCM, and then also the PDS component. What is the overall strategy that you all would approach to the complex plane? And finally, a specific question for Kewin, because in our previous chats before the meeting, a lot of conversation to and fro about probiotics and how you believe that probiotics to a large degree, can actually function also as a neuromodulator. So with that, I pass the time to Kewin and Professor Lee.
Before this, how is the patient?
83.
And how long did you have the chronic consultations?
Correct occupation.
It's the gut problem. DGBI, I think the only thing that come out from GI, I think it's true that if we treat the gut problem, the rest will go away. Or trachea, or a lot of the thing is not if you can treat the central is always the gut problem.
Yeah. Just want to add.
Sorry. So try to get them to separate the outside first, or how many of your patients actually always come together as a couple, sit there, or even mom or whatever. So sometimes you need to get a bit of collaborating. Sorry, okay, but they always come together. Sometimes it's very difficult to we don't get the real story. trained in psychology. But the more you only can rely on your sixth sense. Because I cannot tell you why I feel like this is the case. You cannot tell you also unless you ask patients. But to us, sometimes, this is sixth sense. You have your sixth sense, let's say you're doing medicine and someone is going to collapse, right?
Lot of seven.
You see a patient, a junior cannot tell that this patient after another 10 minutes is going to be ICU, already if you don't shoot the patient around. This is your doctors. It's never in your, that's all. If the patient fulfill any criteria for that. No. So you see already, say, no, this is going up ICU. If not, you got a lot of doctors. This is your doctor has a sixth sense that you develop by seeing this group. But if you have no time, if you don't observe patients, and you lose this case, because if not, you become a checklist. Upper GI pain, this kind of pain. But the overall, you're not going to be able to help them. That's why this group of people always go to different people. They would tell the doctor today I come here because me and my husband are not, no, or doctor today I come here because I have constipation problem. They don't know actually. So it depends on your skill to actually dig up a lot of all these kind of problems. And another thing of that is all your clinical skill acumen, and you think that this is something not right. For me, I wouldn't let my patient out until I feel that they are satisfied. And then that I feel that I have really knocked them down or I make them cry. My person used to hate me because I them cry. They're like, okay, lock there. I don't care, man. I like race them down already. Prepare the people. How you do it? What is the thing? Then they got a lot of new issues now. That's why a lot of they did if there's a lot of the issue or license whatever, so even driving car, they're not allowed to do. So this is real, huh? It's not that hey, how come we don't accept? They maybe accept, but actually you accept you don't do this, you don't do that. It's a very, very big problem for them. So you cannot just say that I refer you to this because then they have real implication for them. Saying that their problems and they have stigma. My patient also got the legit psychology also, but I changed it to GI wellness. They're stressed. They're stressed. Distress like I mean, copy anima, all that. I tell them that it's a distress, stress. Wellness feeling a lot. I feel like this is a very nice word. Outside people can use it. I also can use it. Yeah.
important. Right. Have a second case. Anyone has any other questions? Burning questions? Okay, so Hizami is on the screen right now. Hizami, can you hear us?
I can listen to you. Yeah. Can you listen to me? Your audio is breaking up, but I'll do my best. Yeah, yeah, yeah. You sound like Terminator to me, so
Sorry, but by the way, help yourself to the kueh and things like
I
that.
can hear you very clearly.
okay, perfect. So okay, let me sure. Let me start the slides presentation. Yeah.
By the way, we miss you, Hizami. Life is not the same without you. The land is very cold and lonely.
Rejoice.
Okay, so
You must feel very warm now.
uh, okay, so yeah, can I start? If I really the audio from USM side is a bit poor, but if you don't mind, I will start now lah.
Okay.
Can Okay, sure.
Yes.
All right. So thanks. Hizami, one of the fellows. So thanks a lot. I actually feel horrible because I can't join there in person, but somehow the timing is not right. I'm starting my work at the new place tomorrow, so I need to prepare myself mentally and physically. So thanks a lot for still letting me in and present this case. So let me start. By the way, welcome Dr. Kewin to Kelantan. I hope Joash didn't kill you with all the food yesterday. So, so yeah, I'm going to present a case. This is basically a case that has stumped us for the longest of time lah. She's still with us. This patient is really well known to Prof. Lee and Joash. So, I'm pretty sure they will be willing to add on to this presentation. So I have a 30-year-old lady who actually presented to us initially with the complaint of recurrent colicky and burning abdominal pain with loose stools 3 to 4 times a day, Bristol stool of 6 to 7, and the pain is worsening post defecation. The baseline pain score every day was 3 to 4 out of 10, but can worsen up to 9 out of 10, which will require admission. And it's usually at the lower abdominal region, no obvious identifiable triggers, no bloating, had some sleep disturbance due to the pain, and has been worsening over the past 3 years. And all this started after her laparoscopic appendectomy in 2022 for appendicitis. She will require recurrent hospital admission, but the thing is, initially she will be admitted to other hospital, which is another she'll be admitted to another public hospital in Kota Baru, not to us lah. So but the frequency of admission will be 2 to 3 times in 1 year for worsening abdominal pain, which will require analgesia of various types. So every time she will come in, she will have either ketamine infusion, fentanyl, or morphine, depending on which doctors are seeing her, and depends on whether they are actually getting the acute pain service to see her that day. And she's also dependent on multiple type of analgesia, usually NSAIDs and paracetamol. She had history of nascent fundoplication for GERD in 2016. As I've told you before, she had laparoscopic appendectomy in 2022. She's allergic to many medications. She had a family history of colon cancers involving his aunt and uncles. She works as a wedding and event planner. So she's initially a very bubbly and lively person. And she has no significant major life event happening over the past few years. At the same time, she's also investigated under neurology for chronic headache. So it's mainly right-sided, happening almost every day. No obvious relationship with the abdominal pain. According to her, she had a CT, only shows vascular loop type 2, which is most likely unrelated to her migraine. And this is also managed mainly with NSAIDs. So the way she presented to us is quite dramatic. So her first contact to us was in December 2025. At that time, she was referred for hydrogen breast testing to rule out SIBO. And what happened is she came to us. She was given a fructose solution. She was in extremely bad pain after that. She was screaming in our small lab. We have to send her to emergency department. She received IV fentanyl. For that, stayed in the hospital for a few days and then subsequently discharged with non-steroidal anti-inflammatory drugs. And then after that, everything went downhill. She was basically getting admitted more and more frequently. In January, she was admitted for another episode of pain, consulted acute pain service, discharged once the pain score came down to 3 to 4 out of 10. Initially, we tried a bit of antispasmodic agents, probiotics. We gave her a low FODMAP diet advice. Had another episode in February. We started a bit of neuromodulators, amitriptyline and pregabalin, and then we actually try to treat empirically with rifaximin 550 milligram OD, TDS. But unfortunately, what happened is after the first two doses, you will have severe headache, requiring analgesia. I keep telling everybody that I keep telling her and keep telling that this is not related, but she basically refused to take it outright. And at some point, the headache got so bad, her BP shoot up, and she required a CT scan, to rule out intracranial bleed. Fortunately, this is a normal CT findings. She had another episode in March for another episode of severe abdominal pain. Again, receive IV morphine. I Basically, I'm probably a bit overzealous with the neuromodulators. I actually attempted to increase it to 25 milligram BD, but had excessive drowsiness. So we tapered it down to 25 milligram in the morning and 12.5 milligram on night. Added agomelatine, 25 milligram OD, and somehow the pain was controlled and she was discharged. In April, she said she had better symptom control. And as you can see, her neuromodulators are actually it's quite a lot actually. She had amitriptyline, 25 morning, 12.5 milligram on night. She had pregabalin, 75 milligram OD, and agomelatine, 25 milligram OD. But she is still, even though the pain is a bit better, she is still keen for the complete resolution of symptoms. Her her investigation was actually quite unremarkable. Fecal calpro is slightly elevated. Serum IgE is normal. CT doesn't show anything remarkable. We did a colonoscopy, which is essentially normal, but we actually took a biopsy. The first biopsy was actually quite interesting. It shows a bit of patchy mild increase in eosinophils in the lamina propria, up to 30 per high power field focally. And we actually discussed this extensively with our pathologists, thinking whether this is actually eosinophilic colitis, but they were adamant that this is not because it doesn't really hit their limit of eosinophil count to call this as eosinophilic colitis. So we didn't end up giving her steroids, but what we do give at this point is antihistamines, which is bilastine and famotidine. And then we keep increasing the neuromodulators. So the amitriptyline was now 25 morning, 12.5 gram on night. Actually added on the duloxetine on top of agomelatine. Pregabalin was now BD, and unsurprisingly, she's now getting more and more constipated because of the constipation of the high dose amitriptyline, plus the fact that she's now getting more frequent admission for the pain, and she's been receiving more and more opioids. So ended up giving her Elobixibate 10 milligram OD. She had a repeat colonoscopy recently in June because she said she had an episode of PR bleed. But the colonoscopy this time was normal and the biopsy was also normal. Over the course of the past few admissions within this year, she also had 3 transabdominal plain block, which is the latest one was in early June. The first 2 block actually according to her, she said she has marked improvement. But the latest one in the region actually doesn't show any improvement at all. And we actually saw her last time in DGBI MDT clinic. Basically, we have our clinic once a month where we sit with many teams. We got somebody from dietitian, we got representative from psychology and psychiatry. We had a very enthusiastic neurosurgeons who are very interested in GI neuromodulation, and we decided that probably all the neuromodulators are not helping her, so we taper it down. We had a representative from the rehab team who suggested abdominal core strengthening exercises, and we are thinking about advanced GI neuromodulation. I would probably have to state as well that clinical examination actually is more consistent with what looks like a central abdominal pain syndrome, and we are thinking about anterior cutaneous nerve entrapment syndrome because the pain was very focal. It was right paraumbilical region, and the pain is and there is a focal tenderness at that region. So her latest admission in July 2026, at by this point, she basically had the worst episodes of pain ever, and this is triggered by by a bowel motion. This time around, the admitting team actually didn't wait for us. They actually talked to the surgical team to rule out acute abdomen, and they actually went in for a diagnostic lab. And unsurprisingly, the intra findings are there's nothing remarkable. There's a bit of minimal additions. They done adiolysis. There's minimal free fluid in the abdomen. And even though this has been done, she doesn't show any improvement at all. So and and there's a bit of stigma regarding the whole admission episodes. I have to give credit to Dr. Joash regarding this because she's the one who's actually able to pick this up. So apparently, according to her, she was treated poorly during admission by the nurses, support staff, and doctors alike, and she was labeled as somebody with a drug-seeking behavior. So they told her off that you're just seeking drugs. Sometimes the medications are deliberately served late by the staff nurse, and then everybody was frustrated because each of her admission took some time and is taking up bed space for critical case. So moving forward, what will be the best course of action moving forward? So we are, looking at the psychotherapy approach, and we are also thinking about advanced GI modulation, the transcranial magnetic stimulation, or vagal nerve stimulation, and then and then there's and then we're thinking about fecal microbiota transplant, and then any other suggested non-pharmacological intervention, and whether there's any significance of eosinophilia from first colonoscopy related to IBS. Either we are overzealous in our neuromodulator use, and is there any other investigation that we need to do? So our current working diagnosis will be central abdominal pain syndrome or either acquired anterior cutaneous nerve entrapment syndrome. So we were really eager to get your opinion. She is basically texting everybody every time she got admitted, especially Prof. Lee lah. So we are really eager to get your opinion in regards to how to approach this case. Thank you.
Yeah, she just admitted, so maybe after this can help me to review her together with Aisha Shafi, your patient. it's a challenging case. So we want to get opinion from a lot of experts, like including Kewin. Maybe what do you think about this case?
So this case right now is 30 years old, is it? So staying with who?
Stay with the family members.
How's the relationship?
Good relationship, but her mother currently is feeling unwell, so has to be taken care by her auntie. But she also always taken care by her cousins. So in the ward also, her cousin will come and look after her.
Did she ever get any job before?
Yeah, she event planner or like macam like work from home base.
School time was okay. Last time, so schooling was
Schooling was all right. They had no significant traumatic history. In turn, she was an avid traveler. She likes traveling. Yeah.
and her pilot process, good was done here. The operation,
Yes.
the fundal, it was done here. Was it formally diagnosed?
No, it was not over here. It was somewhere else.
Did she get a HRM or whatever PH before she get this, or was it just done by
No, in fact, she's so sensitive that she didn't even proceed to do the manometry test. In fact, when we did the prep testing, right, we give her sugar. She already crying. We need to rush her to the emergency.
So if you see this patient, right, first thing first, the big word of hypochondria is probably there. Put that first, why? Because 16 years ago, she had the first operation for possible functional GI problem, but don't know about why she was it done. Was it, that's what I said, was it formally diagnosed? Was it because was it really a girl doing that kind of OGD, whether there's esophagitis, and why was the procedure done? And after the procedure, how did she feel? Did she feel like everything was settled because the procedure was done? Second thing, the second operation, the appendectomy. What was histology?
Because it's done in other hospitals.
Again, how many papers have shown that people with DGBI have had appendectomy, have had uterine surgery, and it mimics. Because anyone that you go to any hospital, so severe, they open her up, and then they'll take appendectomy operated before. Then you'll get a bit of whatever, and say that it's appendicitis. I bet you that appendicitis is probably not appendicitis. Also, it's a cry for help. People have surgery, clean out, and that kind of surgery also may make it think worse. It's quite clean. Just go in, not burst anything. Then that time for sure given antibiotic, those kind of thing also. So a lot of this kind of almost like even worsening of post-infectious after changing. So on top of whatever happened before, they have this kind of post-infectious thing happening. And now she's getting more and more and more. And right now, go to the hospital, just have another surgery. Why? This patient is known to, let's say, even drug seeking behavior, or known to be in DGBI. Why is she getting adhesion? Adhesion suddenly comes to the picture. We have been treating her like a DGBI patient. She shouldn't have got the surgery. This surgery obviously means nothing. Because it's a wrong move. So she keeps getting more invasive things done on her.
Yeah, I think the problem is like she came in with such a severe pain that the doctors at the ED, they already think something is in the abdomen. That's right. So they didn't even consult us. They went ahead and asked the surgical team and do the surgery.
Dangerous, because you can see she keeps getting surgery that may not be indicated. Okay, we're just saying here, I'm really all indicated. I don't think so, but may not be indicated. I mean, she has a central problem, which is more of a psychological pain right now. Have been getting morphine or opiate for how many years?
Since our year with breakthrough, with a breakthrough pain,
So,
and this is
I think another thing is an opiate-induced problem. she have other issue, prolonged opiate-induced constipation, the treatment is different. It's actually taking out or removing the opiate rather than putting more and more on. So it's a bit different now. And she actually psychologically, I agree with the psychological part. Now, if it's in any way, she's those kind of patient that want to keep see me every day, and see my face, and she probably want to do that to both me. She's the only thing that is her savior is positive face. And they will come in whenever they can see her in. I try not to be around actually, and they will go home when he's going overseas. If that happen, but the fundamental issues now is what is real and what is not real for that. All this, there's so many neuropathy and the opioid. So I think the first is whether there's any opioid-induced problem there. That's one thing. And you need to talk to actually we look at the patient's other symptoms. For example, was she think have we ruled out? For example, although are not important, these are just think about for any refractory DGBI. These are something that think about. For example, medial ligament syndrome kind of thing. Have we look at that also?
I think we did a CT scan already. There's no evidence of any medial acute ligament syndrome now. So there's no SMA syndrome also. In fact, I think Hizami has a look at that too.
Yeah. We have ruled out. Yeah, we were thinking about SMA mouse. We talked to the radiologist. Apparently, they said there's no evidence to suggest it as such. We also thought about repeating the CT, but they said no, it's not needed. We can confidently say that there's none of those.
So, mouse SMA is another one, which is Newcastle syndrome. These are all kind of things that you try not to diagnose because it's very hard to get out of this because it mimics so many things. These are difficult things. But another thing for these patients that come to mind is something that comes to mind just now, but now not in my mind already. That was sorry, I also
Maybe it's hypo, guys.
There's a very interesting fact about this case. Again, have we fully treated all the main pipeline for the constipation, the other part? Because I saw that she's only on Piloximab 10. Is it enough for her?
Right now, she has, since this current admission, holds of she had a passing motion, they sought to restore 4 to 5. So at least this is an improvement compared to previous.
Yep.
Previous, she was very constipated with a lot of weekly motions, which don't want to do.
And her main complaint now. What is her main complaint now? And is there any, what helps? Does she tell you which helps? There's so many things there.
Initially she responded to amitriptyline. There was a period when she was really almost like pain-free, but then after that she came back again. And when she came back, it's always that focal pain that you all mentioned. So in fact, there was a time when the APS did the nerve block so successfully using the right cocktail. She improved a lot also after that. Yeah, so I do think she has two components. One is the anterior cutaneous nerve entrapment and also the central pain. These two.
So this one, the thing I forgot. Now I remember already. So this group, right? Later we talk about. I'm not sure whether you asked about all those, or autonomic kind of symptoms. We talk about that later. Don't talk about this here because she's very young. Any young patient that present with this, you want to know whether make sure that she doesn't have any autonomic system. You know why later. But
in the afternoon, the small fibre.
after that, you go back and ask. You go back and ask. So until proven otherwise. So for example, COVID, make her worse, those kind of thing, and those kind of questions, you have to go and ask. And this is a complete nausea and vomiting, right? Yeah. So gastroparesis is not a problem also, right? It's just a constipation initially, this kind of thing. Yeah, this is very quite typical. But never mind, just talk about. You'll know about that later. That one is when it comes to about the eosinophils, it's actually no harm. Especially for pain, try a bit of the antihistamine and
Yeah, in fact, she's on famotidine, H2 blocker, as well as a bilastine, which is a H1 blocker.
So how does it? So
No,
bilastine,
yeah.
So can you try?
Yeah, the bilastine is a H1. Yeah,
Different, but besides bilastine, so
and the famotidine.
yeah.
So we already blocked H1, H2 already. But she doesn't seem to have any response.
So we are actually coming to that what you said, the central and northern syndrome as well as actually when it comes to central syndrome means that it's almost refractory. DGBI, what is your workout? What do you do about this? What are the things that now in this group of people that you need to rule out, from just now the people that are the pots, the mouths, this kind of thing. Slowly you have to rule that out. But the very main thing with this group of people, but I tell you, she has been suffering, and we have been, which is very typical of a lot of all these DGBI patients. Multiple surgery. The one thing that we cannot let thing happen to her is more surgery. And that's real. She cannot afford to have more surgery. If not, the next thing that you're going to take out is going to be her uterine. It happens during her menses. They're going to take out her uterine body already. Think about that. And then we are doing this sort of disservice.
Yeah, I think we're going to tell patient that she shouldn't get any more surgery. I think we need to tell her. You tell her that because the other day, that time, I think everyone is convinced that it could be because she had something in her abdomen. Yeah, but now that everyone is convinced there's nothing really there, hopefully she will need to tell the doctors that she wouldn't need any surgery. That we'll let her know.
And the worst thing is now that she has a few times, then really develop adhesions, and then it's very obvious and very different. So
This is her 8th admission for this year.
it's it's not many. It's actually good enough. Just the right amount.
Just the right amount.
Right about admission.
That's very reassuring, right, Hizami? Very reassuring, right?
Just the right amount of admission.
8 je.
8th admission.
There are people, for example, who will know my schedule. How many weeks I work in hospital, they will come in for that amount of time kind of thing. Yeah, I'll refuse to see them, but they'll just come in now, okay, they'll come in now, because I tell you although we keep saying that DGBI, that when is it DGBI, when is it, the one thing that we haven't discussed here is, when is it DGBI and when is it somatization? It's a very bad word, we don't like it, but it's true, What is it? The boundary. What is this somatization? And if I tell you that this is totally, in this case, it's discussed in psychiatric.
Yeah, in fact, psychologists have seen her.
As in, among the psychiatrists, they will have a different diagnosis for her. We have a different diagnosis. They will have a different diagnosis for her.
Yeah, psychiatrists probably will label her hypochondriasis.
But psychiatrists already saw her a few times before, right?
I think the psychologist.
No,
They
psychiatrist.
don't know.
There's no anxiety. She scored very low for anxiety and depression. So
Yeah, correct.
Yeah. So I tell you what. I'm joking here. One of the things that I tell my group is, your groups will feel the same. If Prof Lee cannot treat that case 50% is more of a psychological problem or a psychiatric problem. It's because if you're a ceiling, then too bad, then there's a ceiling, for the patient that's come here. Because there makes no difference whether we say the DGBI patient or whoever that can help the patients. Now we are struggling, we try whatever we have, then it's really up to the psychology if they have more stronger thing. Obviously now we are talking about TMS, which is all good, but bear in mind that the patients may want to have more. If she's right of mind, she has been having pain for so long, why is she agreeable for a surgery?
one thing is like this, at least this patient, she agreed to treatment. I have patients that you know, outright is DGBI with psychology. They don't want treatment. There are some that they are very extreme. There are patients that they wanted treatment. There are patients that doesn't want treatment. Yeah, so at least this patient, she agreed to treatment. She willing to try all kind of neuromodulation put to her.
Yeah, see, that treatment, everything you say, so you say you want to take out the brain, also maybe you're like going to level so this is actually a very good introduction later to a late afternoon session. We never even talk about autonomic symptoms here at all. If you go and ask her, she actually maybe one of you should go and ask her whether she have or not during the prayer. Whether she have any autonomic symptoms, like does she complain of tachycardia? Does she complain of any, sweatiness, hand change, color changes, dry mouth, eye, whatever? We'll talk about this later. Hopefully she doesn't, but it's because the only difference between this group of people and those with a bit of neuropathy is whether we ask these questions or not.
Here. Whether you ask, yeah, okay, we're gonna ask, yeah.
Cool.
So after this, maybe you can work out a bit on the dysautonomia.
Yeah.
There are a lot of these kind of patients lying around, but 50% of my patients like that, also those severe ones. But a lot of 50% of them are small fibre neuropathy, but another 50% are just coming to the hospital to visit me. We try not to do. You see, the thing I tell my team, I just say that first, do no more. Don't do anything. Nothing they will do to change the place so far. What do you think anything else we could do to change this before we change here? And what they want is actually a lot of times is acceptance, is you wanna know that and appreciate that she is suffering. And she's not.
In fact, that day she did have a session with psychology. What they found, psychology say is she has this cognitive inflexibility. That's the term that they use. So that she's very focused and rigid on her symptoms. So one of the treatment that we ask psychology to help us is to do a bit of diversion away from the symptom. She's now too focused on her pain already.
Yeah.
So we need to do some psychological intervention to divert her attention away.
My wife suffered the same thing also.
Means divert the attention from you, is it? Yeah.
But it's
That's my marriage.
Yeah.
To be honest, we have a lot of this kind of patients, but luckily also not many. These are some of the things that patients that they actually, the inpatient team is what they see. DGBI is, which is difficult to treat, nothing. Not a lot of them are like this now. Our patients actually, majority actually can be better. 99, I would say 95%. These are the 5% that actually give the feel, don't know what to do and stay in hospital for the longest time. Yeah. No one answer, It's actually one answer is the doctor-patient relationship. She won't be suddenly, I'm cured. No, don't ever. You always have a target which is better a bit when you want to go home. Actually, for me, from ours is like when you want to go home. I'm not here for Saturday anymore. Doctor, okay. Then the Friday go home already.
They didn't ask you when are you coming back?
And they know because they have my schedule one.
Oh. So they go home, they rest at home, then you come back, then they come back.
Correct.
Right. No, that's right. Right.
If let's say come and we'll scold them, Other attending come and scold them, we go home, Nothing wrong with you, don't talk to them. They also don't want to, stay there. That's maybe because they know that we are those people that will talk to them, take care of them. But other people come, no, you go. They don't feel good about themselves. With us, they feel loved, You know what to do? But I don't know how much I can help them. But clinically, whatever they were done, done okay. It's actually doing more than what other people will do. Think about that. So it's not that you are not doing more, but then maybe if they are neuropathy problem, then there's one thing to think about. But that's what we found. But otherwise, it's a lot. It's actually, I always feel, if a group of people try very long or something, then that patient may not belong to your field. That's why you feel very You can't be dealing with them, right?
Yeah. So anyway, I think we should start cutting down a lot of our drugs already.
Why don't we off all the analgesic and give the placebo, the normal saline, then say that it is analgesic. Don't mention to see whether the I don't know. It's quite difficult
Only the parents or you can hint to the patient's father relative to do that themselves. We are not allowed to do that. I did that once to my patient also. Like the patient said, even NJ feeding like 5 meal patient also complain of cannot increase to M10 meal. True or not? Then I tell the parent, hey, you try to like change the thing. Or really they change a bit 5 meal, 1 farm meal or no. Pay, cannot tolerate. Okay, it's real. That's my neuropathy patient. But yes, we always have placebo that we can give to the patient.
Okay.
Can Happy
Happy, Zami.
Doing alright, don't worry.
We try.
Zami, no longer your problem, right? No longer your problem.
It's not you. Yeah.
It's Joyce.
I tried for 6 months.
You have done your part already. Okay, I take over. Hey, thanks, Hizami. You can stop sharing.
Okay, thanks.
Thank you for sharing.
How about fecal microbiome?
Thank you.
FMTs.
Again, these are all things that we can try for the patient, but the success rate is 50-50. FMT, your TMS, you can try. But the problem is then you better don't get this kind of people into your study group. Because you don't know what's going on with them.
Outcome very weak.
It's just the placebo effect is just the best thing that you can hope for this patient.
Understand. Okay.
Okay. Thanks, Hizami. Thank you so much.
But soon.
Hey, what's the next program?
Thank you.
Ready for your next lecture?
Oh yeah, can. I'll be faster.
No pressure.
I'll go back to my normal time.
Yeah, let's go for a quick toilet break, guys.
5 minutes.
Thank you, bro. Thank you.
Don't bring the computer to toilet,
We don't dare. This one costs 150 ringgit.
Which one?
Your shit costs 150, yeah?
Who? What?
Your shit costs 150, yeah?
Oh yeah, this one, nice, right? I haven't stopped recording it, we are now talking about my baju during a DGBI class.
Biopsychosocial.
Biopsychosocial.
We have to talk about everything.
Yeah. Baju also.
Okay, I'm gonna mute everything.
Yeah. Then you can off your video lah.
I go downstairs and the toilet because someone's using the mic.
Actually, I also walked to I also like I couldn't find female toilet.
Oh, tak ada dalam ni. Dekat hujung sana tak ada. Oh,
Saya cari tempat ni pun dah macam I walk up and down until I saw Dr. Zikir. Oh, please show me where's this place. Huh? Yeah.
Where do you come from?
I'm from Perak, Taipei.
Before this was Buddha, I was
Oh, really?
a lot of Sabahan's ex-couple
Diners.
It's a nice place.
Don't know, when I left the place, I think I missed the place.
You miss the calmness of
The calmness, right?
It's not calm. I think patients will be like, really severe patients. They won't, because they won't turn, how to say, they will present to us like at 38 weeks with 3 pregnancies. So I was in this week. So really, the scariest is of the big patients.
Because they're not seeking for early.
Yep. And mostly in Sabah, is Filipinos, right? They are non-nationals, so
banyak lah.
The problem with a lot of these this disease are very difficult because we don't have enough drugs. We don't have enough for dyspepsia. How many drugs do you have? For bloating, how many drugs do you have? Imagine you have 20 drugs, and they'll be very happy. They can say everything 20 times. But how many drugs do you have? Less than 3, 4? And that's the problem. Yeah. Okay.
After your session, we will break for lunch. Just putting it out there for you.
Alright, so this session is only one slide. Cheers.
Too honest already, too honest.
No, there's a lot of slides. Okay, let's start again. So nobody online, right?
His army is there.
Oh, hi. Yeah.
Or at least he pretends to be there.
Okay.
Yeah, I'm still here. Yeah, I don't
No, sorry.
Now we have to pretend to work again. Alright, let's continue on today's journey. So obviously we'll talk about our Asian things, and I'll talk about Rome still initially try to resist there's an upper and lower kind of thing, which is not wrong for some of them, but actually, you'll hear why overlap is now the keyword. So the illusion that you have esophagus, you have GI and bowel and erectile disorder. In real world clinics, really, they don't come in isolations. And if you look at the study, this is one of the main study, I think. Probably is also involved in this. Is a Rome global epidemiological study, 57. A lot of patients actually have overlap problem of. Only about 40% have, 40% have at least one. 32% have, most of them have more than one. You can see one region is 80%, two regions 22%, 22%, three regions 7.1%. A lot of patients that you see don't just have IBS, they have IBS and FD. In fact, IBS and FD overlap has been recognized for, at least in study for the longest time. It's just that they never actually recognized the term. So this is the most common one. Overlap between IBS and FD over 60%. FD even worse, over sometimes 80 or 90%, depending on where you do the study. And what is the problem? What the main problem? Obviously come to drugs, right? Treatments, right? Clinical trials, right? And a lot of our study only recruit people with pure disease. Only IBS, let's say. So imagine if it's only IBS and 60% of them, let's say, is overlap, then you're only treating the 40% of patients. No wonder, a lot of the patients that you see that may be overlap, let's say, keep failing because their disease is not just pure IBS, their mechanism is different. So when the mechanism is different, then the real world is actually overlap, then obviously the drugs will have minimal efficacy, and in fact, that's why the placebo effect is so high. Yeah, so think about it. If you really strictly use Rome criteria, even your clinical practice, but in fact, it's actually used for drug trial for single entity IBS or single entity FD. And it doesn't work in real life, and that's also why the more kind of overlap they have, the more severe kind of thing. Not because it's all in the mind, but because it is also associated with this underlying pathology of the patients, whether it's hospitalization, depressions, other things, and if you miss overlap or just give an isolated diagnosis, oftentimes first time is said, drug trial often fail, and then they go and see another doctor. After they see Joas, they go and see Bomo, because they lost interest in. They lost interest in. Bomo is
Shamans.
They lost interest in Western medicine altogether after they see Joas, changed altogether. And I've repeated investigation with coconut or whatever. Then you see unnecessary surgery, and this time of patient had necessary surgery. Appendectomy rate jumps from 11.2% to 18.4%. Cholecystectomy jumps from 4.3% to 6.6%. And 4 region overlap. Look at that. And obviously the polypharmacy, and that's the problem when we just take one thing and forgot about that is overlap. And not just overlap, but just all patients also have a lot of headache and other problems, isn't it? Yeah. Migraine, nowadays there's migraine, abdominal pain, so cyclic comorbidity, a lot of chronic fatigue syndrome, fibromyalgia, are very complex. Think about it, cardio, there's not always say this. Is there any functional cardiac syndrome?
But neurology, yes. It's nowadays, neurology is a branch called functional neurology.
They want more business.
Now they want to use functional.
Yeah. Says cardiology always give us, after they rule out cardiac pain, then they don't even like to put an explanation, they just put GERD. Then send to us already. Bloody hell. Same ENT also. Yeah, ENT also the same. So but we keep everything because we cover everything. We cover, the functional test pain, we cover functional everything, reflux. We like to keep patients. So all the functional patients essentially from medicine all come to us. Like, you think the rheumatology have how many fibromyalgia experts have you seen? Or chronic fatigue syndrome expert? In NUS, none. Why? Because they rather suffer like equally, like put it in every single clinic, like everyone. None of them want to be my partner of chronic fatigue syndrome or fibromyalgia, which is actually no difference. Actually, those of you who are trained in DGBI, you can become fibromyalgia expert, and a lot of clinic will really hire you. I don't want to talk about this. These are, obviously you have better people to talk to you about this, about pathophysiology, visceral, central hypertension, low grade, all these kind of things, This is the paper that we write. So there is a Rome 5 overlap disease system. You can go and search for them. So I'm in this paper also. So the more you talk to them, the more you attack them, then they cannot do anything but invite you to join them. Then you shut up. So then, because I won't attack my own paper. This is again the talk about overlap. And overlap not just the upper and lower. Sometimes obviously there are triple overlap also. Non-erosive reflux disease. Look at this again. Think about the patient just now. What did she first present with? First operation was for what? The second one was for what? So they don't just have one. They have multiple. They need to be very careful already. And what is going on? What is the problem? They don't just present with one. Even with constipations, even IBS-C and FC, a lot of people like to know. A lot of people ask, right? Is there a difference? What is the difference? Actually, the main difference is probably in some sort of investigation result. But otherwise, they do change. From painful constipation to MSC to dyssynergic. They never appear in just one. That's why 30% of the dyssynergic defecations are in major constipation. So that's what we always miss also. In Asian patients, about 30%. The problem is not many hospitals like this center. Your center have defecation and biofeedback. Actually, a lot of centers don't have that. So it still depends on good medicine to treat and stuff. And yeah, it's a privilege to have treatments of DD in Asia. Overlap doesn't mean just overlap amongst DGBI. Overlaps between DGBI and other systemic. It also overlap of organic diseases. From celiac disease, infection to IBD. But if you ask IBD patient, doctor, they never. How many of them actually accept IBD, IBS? Diagnosis. We accept, but IBD never. He's interested, but do you think any of the IBD doctor will accept this? All right. So a lot of them, but it's quite obvious, right? You can have IBD, you can have IBS. IBS is different from the pathophysiology. It's quite, it can be a continuum also, it can be a spectrum also, it can be a different thing. You cannot hit on your face, but you can also cannot hit on your back. It's two different things. Yeah. And again, these are the overlap. So can be quite high, from 5% to 65%. TMJ joint, chronic pelvic pain, sleep disturbance, getting more and more interesting. The sleep parts, mainly because we can do much more. There are a lot more wearables. Research-wise, is very interesting. Very more wearables and look at that part also. And I believe that there are a lot more kind of study and treatment coming out from that part also. And again, the overlap with psychiatric dimensions, it can affect each other, but also, like what I said just now, after 1 year or so, if you don't treat your CNS or NS, actually affect each other and make a thing worse. So that's why there are so many kind of overlap between that. And the last one, I think RFID. I think here you're starting to do a bit of work on RFID also, right? So 6 to 10%, 3%. There are different kind of RFID also though. So it'd be quite interesting to see what kind of RFID like your local population have. So we found that, for example, in China, they are very much afraid of eating the food itself. Then we did one in Malaysia. It shows that actually a lot of time it's more of a symptom aversion kind of thing. So it's not just food. So different areas also have different kind of RFID. 3 different kind of criteria there. Interesting. Again, this one again is the overlap. That's why if the driving part is the brain, you get a lot of different kind of overlap. Let's run through this because we are quite close to feeding our own GI tract. Yeah. So, you know about the mast cells theory, you know about permeability and microbiome shift, and we know the importance of hormones, and then the biopsychosocial factors or the gender factors is all important. We are jumping across mainly because it's not because I'm hungry, because these are things that I think you can get better outside. We'll try to show you more of a real world example. And this is very important. Instead of thinking of what organ, the new Rome 5 is always about mechanisms. And that's how they bind together the different kind of overlap. The overlap now is important because now we think in terms of mechanisms. Whenever you do your research, the mechanism is very important. The trigger part is very important. Sometimes they obviously overlap as well. Post-infectious food triggers. Food and meal seems to be very important in this Rome 5. I'm not sure if you have read one of the latest study that shows that, for example, even though you may not have food IgE, after insult, when you introduce, for example, food component into the bowel, actually they can have local reactions. So that is a very interesting food trigger paper. In fact, for immunology side, this is one of the highest rated paper on that year. So the immune trigger paper. And so because why? Instead of thinking of what to treat, overlap means that you need to treat different parts, not just one disease. How do you actually do that? So in different compartments also, for example, central sensitization, we talk about using neuromodulator. Just now, we talk about not primary care, then physical, for example, using whether Vega or next time TVM. So these are all possibility. Gut motility, calopride. Do you have linaclotide here? No. Linaclotide is a type of laxative we can use to actually help. Lubiprostone also normal, right? So again, actually, the problem is treating or conservation is after your first line. We have very little second line. It's good that you have ilobisibet. Have you guys described ilobisibet?
Yeah, we use quite a fair bit.
What is your experience?
Nice.
What is the experience of ilobisibet?
Works.
I can vouch for ilobixibad, Prof. Kewin.
Don't I also can. Don't show them this. But anyway, you still need to. My experience is you still need to keep the patients on a lot of the old thing before it takes for it to work.
Yeah, if the patient has already on certain
cannot-
form of laxative, adding the ilobisibad will not get the most benefit. But if you use ilobisibad as a first line, it works very well. Yeah.
Is it 5 or 10?
We start at 10. then we go up to 15 when necessary. If the patient still not responding, or at least didn't achieve the so-called squatting bowel movement.
Yeah, I talked to you before, like, Yeong using ilobisibet as a one agent constipation treatment, don't think about other things also. But they haven't done that study yet.
But we have tried one in one patient. He suddenly knows that Pachi very well. He only works with ilobisibet. The rest all don't need.
Yeah.
Very interesting.
So lack of like lubiprostol last time we also used to have, but now out of the market only. But I think also you think about it, for Malaysia at least, Malaysia only have what ilobisibet,
Have a Risolo also.
Pulacalopride, and yeah. But never linacotide, never in Malaysia.
Actually, before COVID, right, they want to bring in Boston. The company asked me if okay or not to bring in. I said okay. After that COVID hit, that company doesn't come and say anything really.
Yeah.
COVID
So
has changed.
So for me, yeah, I got lubiprostol. Last time it's lubiprostol also. Then now only linacotide, Resolor, at least ilobisibet. So the more you have, the better your options gonna be, and then the better for the patients also. It's very important actually. And then pelvic floor, you guys also the biofeedback. So looking at network and besides, so overlap is very much about trying to figure out what is the underlying mechanism. And also, right now, I think your team also shows that this is multidisciplinary. Next time it can be integrative. Multidisciplinary means that obviously multiple teams are in there. Which is shown in your MDT treatments. You just need to add one more. You can add a TCM doctor and a BOMO, and then it becomes integrative already. Yeah. So in the world, there are only for conservation only one center that do integrative. They have a TCM doctor that is in Suzhou. Just
We also have a TCM, but it's at the PK Cup.
you have to bring him. Ask them to join you online, then you'll become the first integrative clinic in Malaysia or for DGBI already, and you can add BOMO. Yep. So again, these are all the quick part. We're going to a case study very soon now. So the overlap is really the rule, not the exception. So do not just believe that there's only one. Then really organize the organic shadows. So other disease, IBD, whatever, can have problems. So we don't see very much of celiac disease. Pakistan and Egypt. Celiac?
Celiac? We don't. It's not high prevalence.
Not very prevalent in Egypt. In Pakistan.
Celiac.
Sorry.
Celiac.
Celiac disease.
Celiac.
You know the
Gluten.
Yeah, we have a lot of patients with celiac disease. Yeah.
So for them, it's very different.
Yeah.
Yeah.
In fact, it doesn't follow the actual pattern that what we see in the books. We are seeing, two class of patients. One maybe in 20 and 30s, and another one in 50 and 60s.
Yeah.
Maybe Kashi, next time you can share your experience also. Give us a presentation on your experience in Pakistan or Syria.
Sure.
Yeah.
We don't see that many at all. At all, actually, yeah. Just like EOE, I waited for 20 years to do the study. Also never see that many. So there are things that don't come here. Yeah. And over there, like they are. It's just that why do we not see, for example, like for dysautonomia, because we don't have that many Ehlers-Danlos patients.
That might be a reason, but more importantly, our food, our diet mostly it contains wheat, so that might be a reason because we
have not gone out
eat bread 3 times a day, so that might also be a reason. And probably testing as well, but I think we are using more bread as compared to this food over here. So that's why we experience.
You introduce rice, bungkus, you bring there, open up a shop, then you don't need to work already. I think can. We just all invest. Wow, it'll be quite good business. Do you prefer rice or bread? None.
In general, we prefer both, but bread is more, naan is more.
Okay, sorry, I digress a lot. Yeah, multi-training, which actually, we don't need to talk about that because you guys are already doing that. Although, not many hospitals can afford to do that, Yeah, because it's very expensive, for to use that consultant time, professor time, dietitian time.
It's so common in Pakistan. We have, some foundation they are providing gluten-free diet to these patients. So there are some foundation there. They are also helping in managing this.
Oh, okay. Very difficult to find gluten-free food in Malaysia or in Singapore. They say gluten-free, actually not gluten-free one. Yeah, because you need to be very, very careful with, from not just the food processing part, from the farm itself, the car that you use, must make sure it's never contain any other kind of,
Contamination.
yeah. So, and you're allowed to have contamination, even for gluten-free. Apparently, you're allowed to have contamination of 20%. It's just like our juice, you can have cockroach inside. Just like not more than 2 lah. Only 1 is enough. It's true or not? I was surprised.
They cut off
Yeah.
for the definition.
Yeah, correct.
Safety.
Cockroach free.
Safety definition.
You go to the factory,
But cockroach,
No, go to the factory. Imagine because one cockroach go inside, they die, then they have to, then the whole thing is gone. They cannot, a certain amount.
so a fixed number of cockroaches are allowed to enter the farm.
Safety definition.
But cockroaches okay, cockroach is not good.
Same.
Cockroach
Carry
is
good.
different. Okay, I see.
Because I'm very famous, so Jenny come and see me. You know Jenny? From Blackpink, You guys don't follow Blackpink? Jisoo don't come and see me. Blackpink come, Jenny come. No. Oh my god.
I'm confused which one is you though.
Me is the girl crying. Yeah. So 25-year-old female, employment administrator, 2 years of work in the pain. Yeah, correct. I don't want to be too obvious. I actually presented this in Korea, so but I'll change to IU. Another idol of mine is IU. Anyway, frequent loose. Then I hope that one day they will bring me IU. Because they know them. Some of them the doctor have friend apparently. But anyway, frequent loose stools, some relapse notifications, and some incomplete evacuations. Interfere with our work. Eat a lot of high fruit, vegetable, wholemeal bread. Shift work, auto eating pattern, regular exercise, no psychiatric history, no other severe medical history. Check low FODMAP, that herself from YouTube. Some relief. So, this is the talk that I was asked to give about how to treat overlap patients. The answer is there's no guidelines. There's no guidelines, there's nobody tell you how to. People, they teach you how to treat a single disease, IBS, teach you how to treat functional dyspepsia, but nobody have talked about how to treat, multiple kind of things. So this is my effort of trying to bring this together, Not the best, but all of us have their own experience. So I'm trying to use, MDCP because they forced me to use this. But anyway, this is the official. Have you looked at this before?
Yes.
Yeah. I don't know why I use this one. But after you talk about this, then we'll talk about whether it's useful for Asia. Obviously, it's a framework that they're trying to put to say that it's a comprehensive symptom assessment, so that you can sell books. So there are A, B, C, D and different kind of thing. First is to make sure that it's a wrong diagnosis. This one's supposed to be using rule 5 already, Recognize that multiple can work together, it can be an overlap after you talk to the patient. The second part is really the first, so actually focuses on the main one. Sometimes they can have a few, but still, the key one is still the main one. They can have multiple of different kind of thing, but patient always come in with a main complaint, whether it's a GERD, but actually more of constipation, or GERD with other thing, or constipation with other things. So there's always a main one that they complain. And then another thing that they like to do is clinical modifier, diagnosis with symptom pattern and subtypes. Whether this is the part when you think that although it's just dyspepsia, whether it's more of a food related, meal related, stress related, and whether it's because of FODMAP, those kind of thing. So trying to find out that part also when you talk to the patients. And so when you look for this, because it helps to tailor the therapy and where your investigation is going to go. This is all mechanism related. And how it impacts daily life, then you need to say And the other psychosocial modifier, because Rome is run by psychologists and psychiatrists, so it's very important to know whether the anxiety, depression, suicidal ideation, use, trauma, all these kind of things, somatic symptoms, almost all of them are somatic symptoms. Yeah. And these are the clinical modifiers just now that and also together with the psychologist. So when it's post-infectious, postprandial, FODMAP, and urgency, fecal incontinence, these are the things that will change where you're going to start or do your investigation. For example, if the patient fecal incontinence, you're going to point your investigation towards which area. Or with pain, then which one is frequent or frequent. So they try to give you a bit of guidance, because there's so many tests. Where you go and what you need to do first is very, very important. For them, they think that with bloating, hydrogen methane breath test should be the first kind of thing. So it just point you to where then the treatment wise they trying to say where then even with the overlap diseases like post-infectious, which one is will help more, and this is just a very quick kind of picture to tell you that where which one you can use more, which one is the treatments that you can start first. Obviously this is not very exhaustive, but this is what they give for clinical modifier. And the key thing is, I always say, listen to your patient. This one is not by me, This is William Osler. He said that always listen to your patient. He's telling you the diagnosis, but I think the caveat also is always ask the right question also, because he may not tell you what is wrong with him. You have to dig it out.
AI prompts.
Yeah.
You need to ask the right
Correct.
give the right prompt.
Right prompt. I like that. I'll steal that and make it my own. Yeah. You have to ask the right prompt.
It's Lee Yeong.
There, I cannot see one, like Samsung there, Yeah. So it's very important, when you ask the question, to also know what question that patient may not be, what thing that patient may not tell you, and then actively ask them. Unfortunately, study shows that physicians don't let patient talk for too long. After maybe 15 seconds, actually 18 seconds is quite long. See, not even 10 seconds. Not even 10 seconds. No. Just see, it's quite long, Do you feel uncomfortable? But actually, it's just 10 seconds. You need to let the patients have a bit more than that to really let them tell the story. If not, they will sit down. The moment you feel uneasy, actually within 3 seconds, you feel like, So I think let them talk. At least. Here they say 1 minute. I say 1 minute to go out of the room already, but no. Really, they say that you let them talk, then they'll tell you what they want, those kind of things. All of us suffer from a habit of going into very targeted questions, because we think that after one question, doctor, I have bloating. Do you have this, do you have that, do you have that? This is, you haven't finished yet. I think. If you don't take home, don't bet anything. This is the most important slide in your career life. Give that a bit of time. You can sleep also. Then ask the AI to correct. But we don't let patients talk enough. Although even though our consultation may be 5 minutes, we actually don't give them much time. Doctor, I have this. Then when they want to talk, you feel like back check. I already tell you what. But doctor, I haven't. They even let them talk enough, then you won't know their concern. Even though you don't need research to tell you that, but yes, only 36% go to express their full agenda. This is all of us, I tell you, only about this, no matter how good a doctor is, this is the general group of people, 11, this is very cool study to do, 11 seconds to explain their concerns. So how to improve, how to hit the target, I don't know actually. You really, the golden minute, even for overlap, for any actually, just let them talk. Let them talk. Be put inside, put in front of the computer. Let them talk. Yeah. We are so kanchiong, so whatever, the first thing we ask, and I think same also, For me, is are you better? Not better. Shit. Then is are you still taking my medicine? Because the second question is always, are you taking your medicine or not? Why? Because if they are not taking medicine, they'll say, yes, you're not taking medicine. And then they say, I'm taking all your medicine already. Shit. Then I think, what have I not done? What have I not given? Kind of thing. You know, then I have to go through again. But if let's say the first two is a good, the first one is the best. Doctor doesn't how good, okay, bye. You know?
Okay, thanks, bye.
The third one, if you hit the third one, is that you better listen again to what is going on. Yeah, the morning you are missing something. Structured listening, I don't know. I want to listen to this. This is something that I found, and I try to practice as well. I really try to get information. Then also what's going on in your life. It's a very and set expectations. We talk about that also. Listen first, then we will focus together. Listen, and there's always a way of listening. For example, if you are doing this, you're all using computer, right? Like doing things, right? Actually, what I do is I take the basic information already, then I stop. I sit down, then I turn, and I look at them. If it's not a young lady, then I won't hold their hand. No. It's an elderly lady. Makcik, tell me something. You stop. You turn your attention to them. Not like, what's going on? How many of you suffer from that? Don't you put out your hand? I think enough already. Because if someone is doing that, it's very disturbing to the. It's very, for the patient not to tell you things. But if you just need to move down, actually it's time for you to relax. So you'll be like, I'm so tired. I'll sit down here. You pretend to listen. But you said you give it to the patient. You see, Bomo and Sinsen are very good. What else do they do? They take their hand. Hello. How are you feeling? Very good. The hand
Better already.
on the patient hand, you see, mother and baby contact is important because of contact. How do you feel? And what about us? Our distance with our patient. They are really, they're touching the patient and no, I'm not talking about PR, that's different. Don't do that. How do you feel? You feel very sad, is it? Don't feel very sad. Squeeze. No, it's not that. Our examination is part of examination, and some people are very good. They can incorporate a lot of things in there, but it's still examination. People already can tell they're not going to listen. Listening means giving your all. Sounds like a song, Give your all, give your whole to the patient for 10 seconds. That's enough. But when I say structured listening or even listening, is really listening. Because I get into trouble because I don't listen to my wife sometimes. Can you just put down your thing and listen? Then nowadays I'm very good nowadays. I learned. I stopped the video, then I lower down the volume and then I stop. Wait, I want to listen to you. Because I realized that if I don't do that, it's going to take a lot of my time. I cannot watch my movie.
So better settle it out first, right?
Stop first.
Get the wife out of the way, is it?
But it doesn't take that long. Because I realize there's not much thing I want to say. It's either, wash your clothes, wash your club, listen to me, do this, order this, or okay. Then you continue ignoring it. Then you are safe. If you do that and you say something, okay. You're not going to be able to watch your thing in peace. Sorry, I think I have a lot of psychological problems. So
A lot of trauma.
But this is how you face your patients. You depend on whether the patient is going to tell you the story or not. And a lot of people don't do that. And this is a few tips. Do you have any other tips?
I really like this.
What happened to you? Yeah. And hand holding is very important also. But normally the moment you hit that part, they're going to cry sooner, Yeah. But it's okay. The few tips I use when I want to talk about more psychological thing is I use how's your sleep? Normally they say they sleep very well. I say, wow, then okay, they must be better than me. Then okay. But they say not that well. Oh, why? Then we'll open them up easier. Then they'll say, oh, I got a problem. Or if they want, those people want to tell you, and this is a chance. You cannot tell. Nobody will answer you just by you saying, do you have any problem or not in your life that's causing you to have this GI problem? Nobody's gonna say no. Sleep, people are quite acceptable. Sleep not that good. You know why? Because of this. Okay. Have you thought of? But the stronger question that's too strong sometimes is, have you done anything that you enjoy doing yourself, rather than what other people want you to do? People always feel very, I only do things for whatever, then they'll start crying. This kind of question. What do you do for yourself? Not what the society want you to do, not your mother want you to do, not your child want to do. What do you do? Something that you enjoy doing. Not about work, Then they're like, they cry. How about read a book, go for tea, watch. Then that is a way to start also. You must be able to handle them. Don't start something already. They start crying. Hey, thank you, thanks.
I give you a 3-month TCA.
Bye. Thanks. Yeah, sorry you suffer. Bye. Don't do that.
Stop crying.
So, these are the real trips for DGBI. Even though we don't have enough time, this is how you save. You really do a very targeted kind of thing for patient. If you really want to get the answer, if you don't want to get the answer, you don't do this. You just say, all right, I think you have IBS. I'm going to give you these drugs. Share pathophysiology again. So psychological modifier, we talked about that already just now. This is just so. If you according to MDCP of Jisoo, not change already, but change Jenny. I keep changing. Sorry, it's just the same. So it's still Jenny. This is just the name is different. If someone Lisa later, then okay. In China, that changed again. Here I don't know. So obviously, if you follow this MDCP thing, category A is wrong. If you put this and you take for the patient diagnosis, the notes you take a photo and you ask ChatGPT, can you do this according to MDCP assessment? Or they can answer. They can give you this thing. The patient just can you take and then they'll tell you the thing also. Do someone have done some? I'm sure someone have done research in this area and they have ChatGPT about this. Post-infection IVF, low FODMAP is what they care about. Personal impact. So this is a way to, if you want to record the whole kind of, using the MDCP way of seeing DGBI according to Rome. But it's taking a lot of time but also can be quite cool if let's say incorporate AI, let's say next time. Altered gut motility, then you have an area of direction to go. I think this is MDCP is good for robot. Maybe not human, robot. Then they have a direction to go. We are not so standard. We're not so like if A, B, C. We actually a lot of times is like what I think is the next one. But at least this one gives a robot or a student or people who don't really have expertise in gastro to have a way to understand a framework, correct, of helping or managing IBS and FD, that kind of overlap problem. And if you talk about more of evidence-based kind of diagnosis, again, I think probably myself are involved in this. So these are some of the examples of overlap clusters. There's so many overlap. These are the more kind of common overlap that people come up with. For example, FD GERD, EBS, IBS, PDS, IBS, FD constipation, and what you can go and read this paper. Very easy. What do they think is the cause? For example, whether it's impact accommodation, hypersensitivity, or microbiota shift. These are obviously from expert opinion as well as research, and they tell you that for example, how do you approach this kind of case, whether from gut brain, neuromodulator or extraintestinal, or how to improve life. So from traditional, anatomical to more of a mechanism based that Room 5 want you to do right now. Just a bit of change of how you approach that case, And from that, then it tells you, for example, If it's more sensitization, neuromodulator, just now our patients have histamine blockade, right? If it's more of a, you would think that it's eosinophil activation kind of thing. And then low FODMAP, which one you use. So it gives you a direction, instead of just put everything on or try everything, how do you approach the case again and targeted therapy. So there are also drugs that may able to hit two target, so multi-targeted. So for example, Bucalopride is good for constipation, but it's also good for gastroparesis-like syndrome also. So good for bloating, nausea, those kind of things also. PPI, heartburn, baclofen, ondansetron. Ondansetron is a very interesting one. Do you use ondansetron a lot here? What was the dose that you normally use?
Actually, I use lower than for anti-epileptic.
Yeah. Mine is 4 milligram every other day, but it's one is actually quite big, 8. For 4 actually is very strong. There's also a lot of problem with patients given ondansetron is constipation is a very big problem for them. So be careful with ondansetron, although it's probably very useful. I use it because we don't have the muscitron, so I use ondansetron a lot.
We also have a granitron, then I use it for those with refractory gastroparesis.
Okay. So, but this one is for my diarrhea patient. There are a lot of study. They are studying in ondansetron, but it's not that high a dose. So very, very low dose is enough already. Yeah. So these are some of the things that if let's say your patient have target, they can hit multiple targets. And obviously, yeah. So a lot of non-pharmacological. So can pray. BGT, those kind of thing, and then also dietary management. So this kind of thing always remember, but ultimately, they always say MCT also, but I always say, not just MCT, but integrative also, look for BOMO and complementary health also, which is, one thing that you guys probably are not sure can be doing. Actually, I think Joanne's like to do is probably adding that now to primary care also. They are playing a very important role. If you can get them in, actually, it's very good. Again, now she's very happy because she have some plan, reduce low FODMAP diet, maybe just gentle FODMAP, loperamide as needed. Use a lot of loperamide for a patient. And how do you actually ask them to use? How do you use the loperamide? Ask them to actually don't like, use it carefully, but maybe before important dates, then and don't be afraid of the drugs. If they need to enjoy themselves, need to go out, really need to go out, then go out, and take the drugs and go out. During COVID, right, a lot of IBS patients have a very good life. Why? Stay home.
No social anxiety.
Then just poop whenever they want, we can poop 10 times and just stay in the toilet, no problem. And don't want to wear pants, fine, poop 10 times, It's only when they have to go outside, it's a very civilized disease. Another question that you guys think, in kampung, a lot of kampung, the cow, the dog, they eat here, they poop here, so no problem. They have no urgency problem. They are not diagnosed as IBS. Think about it. So a lot of our problem is actually from the brain. Animal poop and walk at the same time. Horses. Poop. Imagine you can drive your car. I need to poop, then poop. Then the car design just open up a whole zone. There are no problem. I bet in Xinjiang they are less worried than us. Because they just go to the road. Sorry sir, I need to poop. Poop, go out, poop, and come back. So,
or in Japan, right, they can very easily find toilets.
Sure not. Where do you go?
Reasonably easier. In Tokyo, it was quite easy. I had
Is it?
It was really easy and it's clean. So there's no social anxiety. As a matter of fact, people look forward to using the toilet in Japan because it's comfortable, it's clean, and they have all the funny gadgets. Like you go into like, yay!
Look forward is
Disneyland! The attraction of using a toilet.
So again, this patient, he that you can consider a natratron, something that works, and then loperamide is really helps also. Then so they want you to think like a village, get everyone involved. But I applaud what you guys doing here. It's actually very good for the patient and it's actually to your own expense actually to help them. So it takes a village to a kampong. But one thing I'm not sure whether you guys are exploring is AI also. Really, we don't have enough. No matter what, we don't have enough time for them. Whether it's AI for pre-consultations, during consultation or post-consultation, you can actually do a lot of things. For example, here I'm not sure whether you're allowed to record doctor's patient communication also.
We don't have that mechanism. Unfortunately. Because in the UK, doctors they carry a recorder. That's how the UK practice, but not in Malaysia.
So this is not just doctors, but patients nowadays carry a lot of AI recorder. So actually you can't avoid that. Some hospitals say you cannot do that, but the patient will carry a lot of this kind of recorder anytime anyway. And actually our hospital, they have Amgen AI also. You don't need to type. You just talk, and then everything will go in there. But all this kind of thing, actually you can.
Automatic transcribe.
Yeah.
In the UK is what.
Yeah. So I'm not sure how is that. Obviously, there are some sort of thing that can help with our IBS or DGBI, because we actually run one of the most time-consuming kind of consultations. Or even like what I said before that, they tell you the patient actually complain of incontinence, those kind of things, then give you a bit of heads up.
And when we type into the computer, even if you're right, it's always incomplete. It can never be the same. It's just like, you hear say, right?
Yeah.
Talk from one doctor to another, it's like passed already through so many. What you write out is just a summary. But that may not be the actual. That is a problem. But if you can transcribe it, everything recorded come out. If there is an AI layer that can help you to filter and summarize it, that's even better.
Yeah, I think that's important. The why although we say we don't talk about overlap now, but actually it's a norm. Actually, it's what a lot of people are already doing now. So it's what a lot of the doctors that's been practicing, and we know that why is this thing very big? Because of a lot of the drugs. Like what they say, you want to use placebo. A lot of the drugs are not better than placebo, which we also tell you that actually placebo is very important for a lot of its sensitivity and stuff. So you need one thing that I also say is my probiotic is very different from probiotics, because my probiotic will make you at least 50% better. Your probiotic, I don't know. It sounds my word. 50% better doesn't mean anything. 50% better can be 50% not better, or 50% better. But yes, but for patient is unfortunately, mine got a professor in front of me. But Prof given me this is actually much stronger. Use that, use that effect to your own benefit, because you know that a lot of them placebo effect is so high in a lot of our patients, which means that doctor-patient communication is still the best, no matter what overlap, left, right, center, is still the most important, and no matter, and if you are not using that, then you are actually wasting a lot of patient money.
To some extent, right, when you prescribe probiotic, doctor prescribed probiotic will always be better than probiotic by outside.
Same my probiotic. My probiotic very good. So identify overlap early. Don't just take them where it is. Listen to them. Use MDCP. No, I don't think we have time to use MDCP unless the AI use for us. You may be quite good, right? If they have an MDCP and then they feel that trait dominant phenotype first, sexual gastroenterology, they always do that. Yes, avoid over investigation. SIBO, really, you know. And the problem is, how many of them after rifaximin they won't come back and see you anymore? They always come back.
So many of them they do need a second dose. Yeah. We look at studies also for SIBO, one dose of rifaximin sometimes about 30 to 40% a second dose.
So yeah, then multi-model, not just, I always say combination, is probably better than just use one and use it early. The neuron 5 actually bring a lot of things up to the surface earlier. Not like until resistant. Even the a lot of Asian consensus now push like if you can neuromodulator that actually changes behavioral therapy early. So multi-model just hit one by one, but also always tell the patients, so that they'll come back. Oh, I've got stronger drug that I want to give you, but I don't want to give you this time, so that the patient will come. These are a trick for those private doctors, not for us. For us, you better don't come back. Nothing else to give you. All right, and that's the last slide for this overlap thing. Actually, thank you very much. Any questions? Yeah.
Patients like food map, right? When do they get reintroduced to the, because basically these are the foods that we have been eating for since we are small.
Yeah.
Because I interviewed my patient so I just got the history that she wanted to try back the food that she has been eating all this while. But the moment she started back, she started to have constipation again, although she's on neuromodulators. So when do we really allow them to, you can try eating back your...
So two things on whether the patient has been really well. They've been treating them maximally. Normally after they are better, they will try themselves actually. Then they'll be better. And after that is to try in moderation. Don't straight away go and buffet and then die. But really, slowly introduce one and second, and probably, she can really tell you how to do it properly. But for our patients, really, you have to treat them until they are really well first. Then only, then slowly challenge them. And most of the patients, they know when they are good or bad, actually.
True.
Yeah.
This I think because it's a lot of things to cover in a single consultation session.
Yeah.
What's the in your normal practice? What's the average time you spend for a patient?
So, for example, my clinic, my practice now, we see about, let's say, 25 max of patient at least, but
I think you say 50.
Huh?
I think you say 50.
Half day is.
This morning he was telling me 50. Wow. Then was that?
And the whole day is 50. So half day is about 25. So within the 25, maybe 6 or 7 new cases. So I give whatever time that I need to, because they will have already, the other people will be wait there already experienced the longest. Anyway, it's until I am satisfied myself that I've already gotten all the story, I understand what is going on. If I don't have a clue what is going on, I'll probably go on. Because why? I know that the moment the patient walk out of your room, is a patient loss. They don't think that if you don't think that they're going to follow your medication order, you're also lost. So you must be able to understand that you are the one that finally talk to them, understand them, and they want to follow your order. You have tried all the drugs, huh? How many drugs do we have? They probably see Prof. Lee already given all the drugs. You're not going to give them anything different, I don't have any special drugs that's only available to me. But my combination, I tell them, the way I use it is very different. I don't know, maybe not be any different, but the way I say is very different. The combinations or whatever that's very different, and you give it to them. And you will know whether you still need time with the patient or not. Whether it's already, the patient want to come back or not want to come back. If they feel that the patient want to come back, I really will just, not to say hold her hand, don't go, but I need to have a feel that, I'm satisfied with the thing. If not, then I also know, shit, this one's going to complain already. Also, never mind, it's okay, So, if some of them are really rude, then you have to let them go. But if those that ask for help, then you give them time. 40 to 45 minutes. But the rest, then if you have two of these kind of cases, already taken up like 1.5 or 2 hours already, then good luck.
New case usually take longer.
Yeah,
Because the new case you really want to understand the mechanics.
Not just the mechanics, what is going on. Actually, the MDCP is not wrong, but I think you built in your own MDCP already with that then you need to know all this kind of thing before you decide where to go, kind of thing. We actually internalize that kind of this, but this one put it out better so they can teach people. But other than that, I recommend see inside Prof. Lee clinic, see how he ask questions, approach the case. Every case is different, some cases are come in already, look at you, you're not going to be able to help me. Yeah, like that, Some cases, but luckily because of the, because they are looking for help, so they'll be more open. Then you already start the healing process. Come when the moment patients see you, that is very good,
The worst will come with skepticism. Because they already think you are the fifth doctor.
Yeah.
I'm saying, what else can you do for me? That kind of skepticism.
Anticipating failure.
So those people who follow me in my clinic, sometimes I see my very bombastic way of talking things. Sometimes backfire. Wow, finally you're here. Congratulations, you're 15% better. Oh, finally you're seeing me. After you see me, you still not get better. I don't think you need to see anyone. It's very bombastic way of seeing things, but also they'll twat them a bit, like you sort of like shake them a bit, but they will not get better, But at least you give them a bit of okay, maybe this time is different. Because like what I said, they already seen 5 times. What is so different about it? If you have tried 5 KFC and they're all shit, you go to the 6 KFC, it's gonna be shit again. You're not gonna be much better than the first 5 one, right? Unless suddenly, this KFC, the face of the elderly become like Jisoo or Jenny. This is different. Maybe I give you a try. But you have to make the patient feel that there's something worth trying.
Prof, how is the experience of fibre in constipation and fibre in diarrhea?
Soluble fiber is good for constipation and diarrhea, both. So it moves towards center. Actually, especially incontinence, with diarrhea one, not because constipation one. Actually, bulking a bit, you also move it to center. So, but when I give the patient say, I don't have constipation, you give me this for what? Then they like keep it at home. I don't know, I never mind. So yeah, so it's in the middle, only soluble fiber.
Good. Time for lunch.
Yeah.
Time for a break. So we can come back. In the last part of the presentation already. I think you're going to give a lecture first, right?
Yeah.
Yes.
Okay. And I think this lecture will be very, very interesting. It's on what we call small fibre neuropathy. Right? And many of our GI conditions may have this particular disorder that we seldom diagnose because of the lack in maybe awareness and also diagnostic tests. So we need Kewin to tell us about this that maybe I'm sure we have any case studies also.
Yeah. So yeah.
We can have some discussion and share some of the cases that I also see. Because I think this is a condition that we need to have some awareness and start looking out for this patient. Without further ado, let me pass it back to Kewin.
Hello. So from very broad, now we go into very extremely narrow kind of thing. I bet you that I'm gonna tell you that not many people in Asia or in Asia actually seen this thing or heard of this talk. So yeah, you're very privileged for George and for Prof Lee to suggest this talk. Serious, it's really quite interesting topic, but it's very still very small, like little baby kind of thing. Okay, so yeah, so but it's not something that is very new to start with. So it's called small fibre neuropathy. And let me tell you why you need to know. This is what I'm going to talk about. Why SFN matters. So it's actually the first time you heard of this, right? Small fibre neuropathy, right? But it's not the first time you see it, Obviously, it's covering all your body. Small fibre, which is a nerve. Your body got big nerve and small nerve. It's let's talk about a bit of the epidemiology, The 1.3 to 11.7 percent per 100,000 person years. It's almost the same as all those like your other neurological disorder like somatic neurosis and other things. So it's actually not a small problem. For example, they found that 85% of autonomic constipation patients just have some sort of autonomic symptom. And SFN cohort, unfortunately, even after they do a lot of investigations, 50% still remain idiopathic. And in our own cohort, that's mine. You look at some 38 patients that is difficult to treat, what is suspected as having SFN. Actually, 10 of them actually have it. So which means that my hit rate is about 25%. So it's quite scary. And I'll tell you what is autonomic problem and SFN later, obviously. But this is just to tell you that this is the how big is the problem. Last time when we in our med school, we only heard about burning feet, those kind of thing that used to affect small fibre. That's what we understand last time. But right now it's really much bigger, which include the autonomic problem as well as other system syndromic preaugmentations. That's why we need to know more about it. And Yep. So now it is big problems. From the burning feet syndrome, now they recognize that actually you usually diagnose it more properly by doing some skin biopsy. And I'm not sure whether if you are in the West, actually a lot more people will be talking about POTS. Have you heard of POTS before? POTS is actually after COVID, actually a very big problem in the West. The POTS problems, long COVID, Ehlers-Danlos loss, fibromyalgia, especially in the early 2020s, especially after COVID. Nowadays, it's actually quite popular.
POTS is a short for postural orthostatic
Tachycardic syndrome.
So, like the name suggests, you have when you lie the patient down and you sit on the patient, there's a drop in blood pressure and they become tachycardic. That's why I call POTS.
Now we're still talking about the association and stuff. All this almost you almost hear them coming together. Sometimes it's very confusing. SFN, DGBI, POT, Ehlers-Danlos loss, especially for the West. So, but they are not identical, they are all different.
So tendons will be the patient will have very hypermobile joint. It's a form of connective tissue disorders.
It's much more common. When I was studying in UK, we actually have a lot of Ehlers-Danlos clinic. Yeah, there's a lot of patients that actually see with Ehlers-Danlos problem, and they have their specific own kind of issue, including autonomic symptoms, including GI symptoms also. But we don't have it, don't see many here. Do you see a lot here?
So I've seen one patient, probably two nurses. So both are ladies, females, very young, in their 20s, 30s. They actually have a very hypermobile joints. One is a staff nurse, and another one is the wife of a tech CEO. And she's also a lecturer. So they are very, somehow they fit into kind of phenotype.
And you can see a lot of them in all those like gymnasts, so like they can do like double, triple joints on the thing. So I suspect, not they are different from Mafan. These are the connective tissue kind of thing. So I suspect most of them obviously they can fulfill the Ehlers-Danlos spectrum. So let's talk about what is SFN and what is it doing in the gut. So all we know that there are fibers, nerve fibers in your body, from the large one to the small one. We are talking about the small nerve fiber, the A fibers, A fiber segment, which actually control your cold sensations, and then your shock, your pain, and then also the C fibers that convey the warmth, and then the slow burning pain, your sweat glands, your blood vessels, and visceral, and involve the autonomic workforce. This is very important, the sweat glands, the blood vessel, and visceral, the autonomic workforce. We know that these control a lot of our body system, including the GI system. And you think about it, besides that, right, these are what they convey, but they also are the nerve ending of a lot of things, including your immunology, including how your nerves are running. But so these are what they are describing, but there are a lot more function that actually not described. These are what we know, because all those corpuscular, all this remember your anatomy class, all this nerve or neuroanatomy one, all the end of the nerve, right, actually they have a lot of different kind of receptor and a lot of kind of usage also. So efferent, paracrine, trophic function, immune modulation, vascular tone, these are all important things that may be affected by small fiber neuropathy. So, like what it says here, just again, it shows that like somatic fibers, stomach pain and temperature, body tingling sensations, and also autonomic normal fibers. Now, the autonomic one actually involve a lot of our GI motility, auto system, and sweating abnormalities. And this is not the for the gut, right? Obviously, there is autonomic and enteric nervous system combinations also. So it can be imagined. The long fiber one, it's not the first time. Later we know that we always see it, for example, in diabetic patients, in Parkinson's patients. Since what is the first presentation? Normally the diabetic neuropathy. The small fiber is often involved, but they also involve obviously larger fiber. But they also have, for example, tingling and those kind of things. Those are the large, your small fiber kind of sensation. But for diabetic, you involve small fiber and neuropathy, and also Parkinson also have neuropathy that involves small fiber, but a lot of the autonomic system are also affected also. So in DM also they will have GI autonomic problem. And these are, for example, the more can be length dependent or non-length dependent. And a lot of them, like what I said, affects two other things. For example, your sensation and then your neuroimmune crosstalks. They involved in a lot of calling our mast cell. We know that a lot of our DGBI involving a lot of immune activities, like how close the mast cells are to the nerve cells in IBS patients. So these are areas that they may get affected as well. So when someone is suspected, I'm going to tell you about how it is diagnosed. But when talk about small fiber neuropathy, right? Just now we talk about diabetes, right? So it started to have, obviously, all those started to have this problem, even pre-diabetic, insulin resistant, and renal disease. Gastroparesis, in a way, is one of the presentations on that. When diabetes is bad, right, then you have gastroparesis problem. But when your diabetes improve, actually the gastroparesis problem become better. This is one of the signs that actually, when the salt is gone, sometimes the small fiber may come back. So it's not like people we're still trying to understand whether it's a one whole kind of burning and then all the small fiber is gone, or is it just more of a diminished. Some of them are diminished, not all, not like burn all and everything is gone. And hopefully with treatments or with things will go back. So diabetic neuropathy actually give you a peak of maybe this small fiber neuropathy may actually get better if you treat it or you treat the cause.
So it could be like we say patchy or segmental involvement, just like the Hirschsprung. The Hirschsprung doesn't mean that it must involve every nerve. There could be sometimes just segmental involvement.
So Hirschsprung, when you take the biopsy, obviously you just take one part, then you may miss a non-classical Hirschsprung also. So, but then how many parts you take? But yeah, so there'll be classical Hirschsprung and non-classical Hirschsprung, just like this, And then again, then there will be other causes. So for example, like your B12, B6, or more likely, people will also suspect immune-mediated causes, like Sjogren, lupus, sarcoids, and Cecilia, doesn't help. HIV, But one thing that I'm going to this part here, post-viral, long COVID. This is very important. And there are obviously some genetic predisposition also, which is here, HERSA, POSA, fibromyalgia. These are all general overlap also. So these are some of the clues. For example, if patient has gastroparesis-like symptom. Although in our Asia, we seldom think about gastroparesis in our diabetic patient. Don't know why. And then restrictive diet, patient with restrictive diet, more absorption, patient with Zika, or dysautonomia. These are some of the clues that small fiber neuropathy or is suspected, or the autonomic symptom is affected. And so these are the group that should raise your suspicions. These are just the different groups. If you have a big Atlas Danlos group, obviously, then it's very easy. 61% of them has small fiber neuropathy, and POTS also is 32% of them. Fibromyalgia, it's been said that 50%, actually have this kind of problem. 9% here, the pool prevalence is small, 9% may actually have this problem. So why are we not seeing why are we not seeing more SFM diagnoses, right? It's because it's not so easy to diagnose. We'll show you why. And long COVID also, after COVID, right, there are actually studies that shows that there are more and more higher and higher prevalence of small fiber neuropathy. And for the longest time, we really know its involvement in Parkinson's disease, GBS, and Pompe disease. Nick Kelly is very interested in Parkinson.
Nick Kelly? Parkinson? Why?
I don't know. So he's very interested in Parkinson right now. So he's coming to Singapore to do that. So he has a paper that's going to present at UEGW. So yes, he is putting a lot of energy into Parkinson's disease. We shall see what comes out. How does small fiber problem then leads to GI symptoms? So small fiber, one of the things may affect your vagal, sympathetic, or enteric coordination, which also include, like just now we say, vasculation, right? Include and then your motor or secretory dysfunction, when you have a combination problem, shaping problem, and also chronic secretion problem. It may also lead to visceral hypersensitivity, and essentially the clinical phenotype is the same. Because if this is affected, it can affect from up to down, or from motility to visceral hypersensitivity to everything. So they can actually mimic the DGBI. Are they coming? Your medical office.
One of them is attending this Monday will come.
Okay.
Later I'll bring them.
Yeah.
And then they also want to run the compass. Yeah.
So the more common problem that actually they will present with include intrinsic GI dysmotility. Then you can actually for my patient that I see, not so much of gastroparesis, but definitely a lot of very severe constipations. Yeah. And others, for example, more of gastrointestinal problem, hypovolemia, and this is the problem related to their control of their volume and stuff, and then this is the main problem. Non-GI, this is the main issue why patients stay in hospital. Why? They cannot get up. The moment they get up, they faint, syncope. So even you want to discharge them out, they came out, they faint, then there's actually overpowering of their autonomic dysfunctions. I've seen some of them stay in hospital for how long? 2-3 years. I have one 23 years old that's been staying in hospital for 3 years under PITS. We don't want to take over, but PITS already. They're staying in hospital for 3 years. They have multiple, like drugs and stuff to help them to try to fight their autonomic failure, but they can't. The moment they stand up, boom, hypo, then they go into syncope. And obviously this is not their main problem, but they get a lot of dizziness and other kind of things also, and then pain. But yes, they can stay. Those that are affected, the severe one, can stay in the hospital for very, very long because they just cannot move anymore. This one is the one to tell that how do they actually present in at least in my own group. This is my own kind of group of patients. They can present with upper GI symptom, early satiety, nausea and vomiting. Nausea is a very, very difficult thing to treat in this group of people. They almost cannot eat. I always have they have a coupled with the sensory amplification, which is when they eat meal, right, you feel very discomfort, feel very painful. So we almost always they'll ask for NG tube to suck and NJ to feed. So they have I call it the Mostet signs. Don't quote me. They're like, if you go on TikTok, they put on there. Here one suck, one in. You see that, you already know that. This patient is in a hospital. Is very obvious one. This is SFN until proven otherwise. So they cannot feed. Then they put it all the way until NJ. Small volume, very small volume. Just now I say about the case about placebo effect, right? The father tried to put a bit, now 10 mil. So you see cannot. For me, in pain, always in pain. We still don't know why this group of people are always in pain. For example, two theory. Sensory may be really impaired, and the second one, they don't recognize the food anymore. So they do that, but that is together with the first one. Why? Because the sensory and things that like you recognize your food is actually not there. So it's almost like a poison. That's why they vomit a lot. They are done. The thing is blood vessels. The control of the vasculatures has been impaired. So it's almost every time you eat, when the food is not there, although you want to send your blood there, there's always ischemia kind of feeling, not enough. It's just food there, but without digestion happening. So you have a lot of sensory amplifications and constipation. One of the patients that I have come in with almost like a pseudo obstructions. Well, it is a pseudo obstruction. With stool all the way until here, admitted into ICU, and have to run for have acute kidney failure, to have dialysis. The surgeon said they want to chop it already, so we managed to salvage the colon slowly, rehabilitate the colon, and then we managed to take out the stool and have enough medicine to cause the patient to be able to pass motions. Almost to a more scientific event. The first time when this patient that I said, was sent back to the community, it was with lactulose and senna. No joke. Just lactulose and senna. And the father, after a while, said that, stop the medicine because the patient have diarrhea. Which in fact, the patient actually have overflow incontinence that time already. Then stop the medication, boom, come to the hospital again. So I have to deal with that one more time. Although the patient was just admitted in the hospital to ICU for constipation, they is not the surgeon. They don't even take the freaking constipation seriously. The patient almost died because of constipation. Lactulose and senna, without even any other kind of education or whatever. Not even TCU like 1 or 2 weeks to see that patient. 2-3 months. Before that, obviously, patient came back, but didn't die. I know. Okay. Yeah. In my cohort, they're almost always young female. 80 or 90% young female, very few male, and normally they are less than, they are young, adult, age 30 or well, probably 15 to 30 age, early society, nausea, vomiting, bloating, constipation, diarrhea, dysphagia, you name it, it's all there, and they also complain of orthostatic intolerance, you got abnormal sweating, that's what I said, and then urinary sexual dysfunction, not have like. And then Siah symptom, dry mouth, symptom, pain and sensation, a lot of burning pain, tingling sensation, electric shock kind of pain, allergia, temperature intolerance. Very typical one. If you ask this question, they say yes, you cannot run away. Later I'll show you the Compass 31 as well, which is the group of patient question that I asked. But they also have other systemic overlap. They feel very fatigued, They feel brain fog, migraine, hypermobility, fibromyalgia, kind of thing. And they give you a very typical group of people. I would say that if you have someone who has a very difficult to treat DGBI and they are a young lady, you probably have to, for us in hospital, it is small fibre neuropathy until proven otherwise. Because we just see so many, so severe ones. Yeah, until they all know, the first thing they'll do is Compass 31 checking for this problem because we just have so many. And so what other symptoms? Pain, I think we went through that already. Pain. Autonomic symptoms include facial flushing, skin discoloration, Siah, sexual dysfunction, bladder dysfunction, blurry visions. These are over. Think about it, the patient have this kind of symptom, right? You're not going to ask them within one time. For my first case was actually diagnosed 10 years about 10 years ago actually. Without me knowing any of this thing, I still very blur also. But patients started telling me one thing and another. The first time that the patient showed me something that I thought is wrong is when she showed me her watch. She showed me that sometimes her blood heart rate go up to 150, 160 every now and then. Okay, brush aside. Take care, come back soon. The next time she went, hey doctor, I always bruise. Bruise very easily. Although she didn't fulfill all the patent's call. Okay, she's very fair. No, it's not. Then you should try, try. Don't dare try to pretend. Yeah. Almost they can do this, they can So it's a very almost Western like because they have more of a
Can join study.
You have got discomfort.
So it's not that they have a special group of people, They have a special. Not that rare. Your room got two already.
Things are very balanced,
Actually, I also have about one joint only.
Yeah, but it's a spectrum. That data, but I can do that also. This is not human. So anyway, so during that time, slowly she showed me this, she showed me that. And it's only also this is the patient I first saw the lady. She was referred to me for incontinence since she was 6 years old. She saw me when she was 17 years old because other hospital don't know how to handle already so long already. So incontinence for like 10 years since 6 years old. Think about that. She came to me, actually we found out that actually she had overflow incontinence. It's actually constipation, not because of diarrhea. This is a very bad case of constipation, cannot control. It's also not Hertzsprung. They wrote already. Yeah. And we spent the longest time. The key is to control constipation. every now and then, then, as we are increasing and improving the management, show me this, show me that, show me that. Now, after that, you try to piece things together. Is it where they made it? Is it this autonomic symptom? So after obviously last time we go online and check. I don't know, what is it called now? I don't remember.
Google.
Not Google. Google got but other thing also.
PubMed
PubMed also, everything also. Check. Then they say, is this patient suffering from this autonomia POTS or whatever? Not even small fiber neuropathy. So boom. Then I was talking to my neurologist. She happens to be a small fiber neuropathy expert. Although she never think that we will have so many. Last time they do have mild kind of constipation problem. So I started with sending her for a tube table to check whether there's any POTS or not. She's just suffering from POTS. Then the other one is sent for the sweat test. Both positive. Then I sent it to my neurologist colleague. And my neurologist colleague took biopsy. Their biopsy quite expensive, 1,000. Don't know why. Skin biopsy, standard one. Check already. Then found that this lady suffered from small fiber neuropathy, which actually explains a lot for the symptom. But I just want to tell you that sometimes they don't tell you because you also don't know. I don't know, she don't know, everyone don't know. But that was about when she was young and I didn't know about this case. Then she became better and now she's a 4th year medical. That time she was just a secondary school student. Now she's a 4th year medical student studying in Australia. So really, want to do like DGBI when she comes back. So that's one stop story. But after that case, I was very, I felt very, excited. I thought, wow, I discovered a freaking new thing already. Everyone I asked, negative. Everyone I asked is not, maybe one a positive, whatever, but most of the time, it doesn't hit high, moderate, or even whatever score. It was just very, very, it was just all doesn't hit any severity for me to suspect small fiber neuropathy for quite long, 4-5 years. Then don't know since when, after COVID, I started to, this guy like that, this patient is the same, young. Let's check. Positive. Then I said, okay. I said, come back positive. Then don't know. Then from then on, numbers just keep coming. Just more and more of this kind of similar case come back. Then I know that. Wait a minute. Are we seeing like a new core thing? Then I actually started to talk to different professors. I think Justin to Henry long time ago, whether they see the same thing or not. Yeah. So yeah, but it's for us. We just keep seeing. At my clinic now is about half of them got this kind of neuropathy problem because they take very long time. Their parents will come, whoever will come. This one they just ask a lot of questions, because these kind of people actually don't get better. They actually get quite bad. But definitely, I don't think it's awareness. Something triggered that. That's why we're seeing a lot.
It could be COVID.
Oh yeah.
COVID-19. Because
The
the
more
viral
effects.
is a very common cause for small fiber neuropathy. Then very undiagnosed.
So, besides COVID, then the COVID vaccine also. So after that, there are a lot more kind of studies show that there are a lot more post-COVID small fiber neuropathy. And if let's say there's a lot more small fiber neuropathy, means that everyone got it right. So actually the number is not small, but there may be some people with susceptibility that have genetic that cause them to have more severe symptoms. But actually the number is not small at all, unless we are talking about because we are in the tertiary hospital in Singapore and we get all these cases, which is Singapore is so small. So actually there should be a lot of patients going around with problems, just that we don't recognize it. That's what I think. And again, it just went through already before. So like esophagus, again, dysphagia globus. This is just tell you that it affects all the way from lung to your anus, cannot run away one, because it is all small fiber nerve control. So yeah, there is this latest paper on pediatric evidence actually. 84% of the SFM patient with pediatric one definitely have GI symptoms, and think about it, 65% in pediatric present GI symptom first. So which means that if you don't catch it, then we may miss it. Then the patient may go some other places. They will forever miss that they may have a small fibre neuropathy. And 4.6% of them have previous confirmed diagnosis of POTS. 100% no manometry. So you can see that actually it's not easy. So quite common problem reported in the pediatric group. Wherever there's ped will become adult. So they will move up anyway. And hopefully it's a small number, but I have a bit of doubt. Okay? And when to suspect is what I want to see, I want to know, right? And how to diagnose, right? Is really when there are red flags. Not red flags to scope, but red flags to tell you that this case might be, small fibre neuropathy or dysautonomia. We keep using that interchangeably because it is quite interchangeably. Like when we say dysautonomia and POTS, then they are the people who suffer the most kind of thing, but dysautonomia more describe the symptoms and the pathology. So, burning, tingling, numbness, the moment they say my pain is a bit of burning pain in my feet that liao, it's almost like, but not in the morning. Then they have syncope, pre-syncope also. First thing, normally in clinic I ask 4-5 questions. I also do the full compass after I quickly screen your problem. Like, do you have this problem or not? Do you get giddiness or not? But a lot of people get giddiness and palpitation, When you say that, what about you get like sweaty palm or change of thing, then the more they say yes, the more like, oh no, then a lot of oh no problem, And dry mouth, dry eyes are very easy to say yes also, but not the urinary problem, especially 30 years old. It's quite rare. Although I guess this have though, the hypermobile type. This one don't need to ask post-infectious. Sometimes say, is it related to COVID-19 immediately? I say, don't know, not sure. So, but a lot of people have that, and some of them can be very rapid. Rapid weight loss, atomic failure. Then a lot of time it just becomes very refractory, very difficult to treat, very refractory DGBI with nutrition compromise, and recurrent admissions into your hospital. That is also a sign that this patient may have a problem. Although we say it's young female, sometimes it can also be older that we never suspect. No, I don't know what to suspect nowadays, but these are the things that I say I suspect. So this again are the few problem red flag. Dizziness, presyncope when they want to stand, sweating problem, temperatures, anhidrosis or heat cold intolerance, burning pain, tingling, numbness, and joint hypermobility, easy bruising. Then screen fragility, recent severe viral infection. These are all sort of like things that you ask the patient anyway, and the patient tells you back. If it's positive, then so one by one, getting more suspicious. If let's say in the clinic, how do you actually do a bedside algorithm? Very easily, patient if they have already got refractory DGBI, then like very severe, difficult to treat young people, suspect may have this problem. Screen for a red flag just now. All those questions that we ask, questionnaire will cover most of that anyway. And that's why I say use Compass 21, 120, points toward more of a mild problem kind of thing. And multi features, and then after that you have to confirm and treat. Why do you want to confirm and treat? Because it may halt the process. Unfortunately, there is not enough evidence to say that whether using this kind of way, using the your base and using this question asked actually help. Not enough evidence. History, you want to, if you have time. Study shows that the only thing that matters is the orthostatic symptoms. Or if you don't have time to ask all this, at least orthostatic symptoms, fainting, standing up, fainting or something. Then joint hypermobility is quite common. The rest actually quite late. Then Compass 31 is what I said. very sensitive but not specific enough, but I can use it. Then after that, a normal nerve conduction study does not exclude SFN. It mainly serves to exclude large fibre disease. Yeah.
Just a curious question.
Yep.
What is the association between B6 supplement use and SFN?
B6 supplement,
for history.
they actually are more prone to there's one of overdose of the B6 actually, but I need to check also. Good question. I need to check why. Yeah. So these are the possible tests. Unfortunately, you can see that a lot of tests are not available. At least here anyway. So we at least in my hospital we actually have skin biopsy done by the specialists. Then they count, obviously the end of fibers. We have QSAT also. These are the machine to measure sweat. Whether you have appropriate sweat response. And then after that, there are people who do the wrinkling one. I think we do also, but I don't know order how wrinkled is your fingers. I think can show that your autonomic system is good. And then thermal detection threshold will do also. Tilt table also, especially for POTS and dysautonomia. And if you have a corneal confocal microscopy, actually this is good also for rapid repeatable correction with skin biopsy. Actually, you can look at the patient's eye if you know how to read eye. You don't know how to read eye, then don't read. Still don't know what's going on. A bit of IPD kind of thing, but actually it's more sort of sluggish control because your pupil, remember, is controlled by parasympathetic and parasympathetic. So when these are affected, your pupil don't know how to constrict whatever properly. So, but these are more sensitive, but we don't have it. And actually, the more important thing is obviously the skin biopsy. You need specialists to do it. I don't know why though. Why can't we do it? Why can't why don't you need a neurologist to do it? I don't understand. Not dermatology, like neuro. Yeah, maybe it's that niche they want to give around.
If our neuro not doing it, we can refer to our dermatologist.
I guess so. It's the same. Yeah.
Wow, that means on the bony prominence can be quite good.
You want to no, don't worry. Because there's small fiber neuropathy already.
So you don't feel the pain?
I don't know. Of course you feel the pain because still got other last level. Okay. Then so the healthy control, then reduce one. Not very clear, but yeah. So that's what we try to prove. Less of the nerve fiber. Use 99 to actually face it. This is using the corneal confocal microscopy. If you have one, it's also very useful. I don't have one. Yeah. Then diagnostic criteria. How to diagnose SFN? It's only until recently that you have more of a confirmed kind of criteria that actually involve whether there is or whether there's a normal nerve conduction study, and also the small fiber neuropathy sign must be there, and obviously reduce skin biopsy, lab screening. These are, if you suspect some patient has small fiber neuropathy, obviously you check out all the predispositions, all there, and then the second line include OGT, diabetic, that kind of thing. So these are when the patient has already suspected to have SFN. Okay, so again, putting it together, the key thing is really the suspect. Without suspicion, you won't catch any small fiber neuropathy. Try them to use Compass 31, really exclude large fiber disease, and then whether it's skin biopsy, QSAT, if you have, do whatever that you have. You can explore the dermatologist also. Maybe it works. First line lab, second line lab, okay? Then etiology directed and treat. Okay, so this is sort of easy one to put together. Again, same in your clinic. If you don't do anything, if someone feels dizziness, palpitations, and if you have a normal sweating, if you do a simple Compass 31, you can almost know that this patient needs to be referred or not referred. And this is one of the studies that we presented in DGBI. We put Compass 31 to all the people that we suspect to have SFN. So not all of them, all these that suspect. They show that there is a trend, and then we have a cut off of when using the 31 item, which shows that you can actually use Compass 31 to sort of like determine whether the patient can be sent to review or to check for SFN. The number is quite high though for 7.1. Mainly because these group of patients are actually very suspicious. So you can see that actually DGBI is quite happy, quite interested in this kind of research also. And yeah, so even after everything, if you have clinical suspicion, for example, a refractory GI symptom plus neuropathic pain, orthostasis, sodium abnormalities, what I've done, and also after excluding large fibre neuropathy, and then obviously you have skin biopsy and QSAT already, then it can be a no SFN, normal, everything is normal, but it can also be probable. Either one is abnormal. So you may read around this thing and hear normal, probable, and definite. This is what it means. Not very junky, not very advanced. This is when they cannot do, especially when they cannot do the the study for the biopsy. Sometimes you may call it probable set first, so SFN rather than a definite SFN. And when you really meet with someone, we say here SFN, you have to take one step back. If someone really have a dysautonomia, a very severe dysautonomia, it can still be all this, diabetes, impaired gut florence, Sjogren's, systemic lupus, long COVID, all this kind of thing to sort of rule out. So you want to do some of the tests here, obviously not all, but yeah, close to already. B6.
B6 toxicity.
Yeah. So correct. B6 toxicity. Just double check. Our agent experience, like what I said just now. This is 12 patients with biopsy confirmed SSN with prominent GI symptom. These are all the patients that we catch in our clinic. If not, it'll be lost. We identified like 5 distinct GI SFN phenotypes. 100% of these patients have one reduced ANFD and large fibre normal. It's a retrospective kind of case series. All of them is the biopsy confirmed, not the probable, but a definite. And we found that there are, some can be upper GI predominant, just at very early society. We showed this just now a bit, but some can be lower GI predominant, like they have refractory constipation and VSD. Some can be mixed, fluctuate up and down. Some can have very severe, like start with very severe cases. Enteral GI feeding dependent, nutrition and hydration become the central clinical problem. They can be suddenly, just cannot eat. And also there can be those with post-infectious or positive serology. For example, this is a very sad. Well, all of them are sad, but this is a 22-year-old woman, law student in New York. Already got an internship in New York, so not easy, quite high flying. Apparently, the father is a previous opposition leader. Presented after a post. I think it's too detailed already. Damn it, man. Yeah. So this is nobody again. Presented after a post-viral illness abroad. I was sick in New York. After that, have developed fatigue and alternating hypotension, followed by bilateral sore pain with allodynia for 10 kg weight loss over 1 month. Woke up. It shows that I suspected when you can't see me, I already suspect, and all my team all suspect. They have neuropathy because our team is just exposed too much already with this kind of case, they are doing this. Sometimes it's a second nature kind of thing. Yeah, it's almost like dengue. If you go to America, UK, whatever, you see this kind of platelet, whatever, you will say dengue. Do you guys even still do the dengue check or whatever check? No, you're still okay. Go home. So until the condition can be, like that,
We should do a full blood count at the emergency department.
Yeah. And after that, yeah. So recognitions, they saw quite a lot, huh? Then this patient went for reduced, went on QSAT, that shows that there was reduced sweat response, also impaired thermal sensations. Tube table was positive for POTS, and also there's reduced NIFT on skin biopsy. And she's getting thinner, so eventually they requested for nasogastric feeding. Actually, we don't encourage that, but she wanted treatment. She actually get different thing, not just IVIG. She even get methotrexate and then rituximab. Compass slowly improved from 29.5 to 19, and that's when we suspect from all the history that she probably had parainfectious or dysautonomia with small fibre neuropathy. Now she's with maintenance rituximab. And this is just a case of severe dysautonomia with quite acute onset, and totally went from bright young girls to depressed young lady. Imagine high flyers, law student. After that, came back, stay in hospital 3 months, stay in hospital 6 months. Totally wrecked her. Currently, we try to encourage. If not, she'll be gone. And still in denial. Didn't come to see me in my clinic yesterday. Don't know what happened. Well, not yesterday. Yesterday is because I'm here.
Because you couldn't.
Correct. I read it before.
No, the more sad.
How come? This is my first case. 23-year-old women student, no prior GI history, presented with septic shock. First presentation, septic shock with Stachora colitis. Stachora colitis means like colitis because of shit, stool. And then with enterotoxic E. coli translocations, complicated by AKI requiring renal replacements therapy. It's really quite serious already, right? Boom! Readmitted after non-adherence to bowel regimen. Although she almost died, this lady in ICU, already almost, but because it was given lactulose and senna and go home and stop treatment by parents because they thought that it's okay, right? No problem already. We have no pain, bloating and vomiting. Now I have to help her to disinfect her. So the constipation can be so severe that it can cause Stachora colitis, and obviously the next step is already talking about ulcer, can puff, can die. So man. So I also use this and say that actually poop can kill. Don't underestimate the power of poop. So what's the difference between what they normally present in the West, like Ehlers-Danlos and this? There are recently, if you put Ehlers-Danlos and dysautonomia, there are recently guidelines from Kasim Group talking about how to take care of Ehlers-Danlos with POTS and SFN. Quite nice. But compared to them, ours is more of what similarity is. There are also many of them are immune mediated, kind of like female predominance, post-infectious, dense overlap with like POTS and other diagnostic delay. But more of it is ours. We actually have a lot of small presentation of first GI content that was like small cohort, and don't know whether it's referral bias or is it a true regional difference.
I think it's probably true because even our SLE in Malaysia, they are very bad. The moment they come in, they have all kind of inflammation, renal, everything. So to some extent, it could be autoimmune also, right? The underlying mechanism, inflammation and autoimmune.
So we have a grant. So look at we have some preliminary result like autoimmune kind of thing. They do have some autoimmune antibody, and then we also trying to look at, for example, the different kind of biopsy to look at the mucosa cell also. So there are a lot of different things that is going on there between the difference between Asian and Western called. This is just a snapshot. But let's continue on the treatments. Very difficult, especially the GI part. We talk about GI part, but obviously the other one is glycemic control, correct your B12, stop B6, reduce alcohol intake, treat celiac disease. This without saying, treat underlying diseases. And the GI part is the worst. Why? They're all the most severe GI cases because they don't respond. And the drugs that we give, is it helpful for neuropathy? I don't know. Is it helpful for, we still need to know what is the mechanism, right? Is it because of vasculopathy? Is it because of vessel? Is it because of heart? Is it because of different things? No. But we throw everything we know to them. And oftentimes they are like, we redo everything and then they are good, cannot, then it's too bad. So upper GI, put kinetic or whatever, constipations, try all, defecatory, if you can, we try. MCAS, if suspected, stepwise also H1, H2, and comoling sodium also with glycate. So these are the GI directed therapy. Answer is they are not very well tolerated. They still suffer a lot, especially pain. Pain is one of them, but not there. But pain is actually GI pain is one of the biggest problem that they have. They keep complaining of pain. And the next one is the dysautonomia as well as the POTS. The other than the fluid, salts, those kind of things. They want to eat, but they also cannot eat. Eat already, and then sometimes time out again. Then some of the drugs that we use, beta blockers, Dorine, Fluocon, these are all for dysautonomia and POTS. Then SNRI and opiates also may worsen problem. And pain. These are just now the patients, that's why I suspected, in a way they present very similar with patients with a lot of pain. So tricyclic, gabapentin, statin, all can be tried. Then the other thing is escape the nutrition, sometimes they don't eat that well. And rehab, if they work with you, that's the best. Most of the time, no. Just imagine the other one that I saw in, I wouldn't look at is we also talk about some of them get IVIG, although there's no much evidence, but some of them that actually do get it because of their very severe autonomic symptom, the GI just get improved. But there's just no study that do out there that allow us to just use IVIG for severe GI symptom. Can we? Why not? But this one need to talk to government about how to use, or whether we have enough evidence to show that immunotherapy is important in this group of people. Actually, we don't know. Where we get it goes. Okay? And for one thing that we didn't put down there is the psychology part. Again, these are very young, high-flying patients, and one of the patients, obviously, just now we talk about a lawyer, don't say that. It's very difficult, it's very challenging now transfer to adult care. There's one that I just saw last week. She will speak to you like this with an eye mask. Then it's all here above. Then there's a line connect to the phone. The friend will talk instead of her. She's very stressed. Then she'll like do like this. Dr. Siah. Okay. Then she go back already, cover everything. Very severe pain, cannot tolerate food. She did go for IVIG, so still to know the result. This is some of the psychological impact that this group of people have, and they almost always end up almost all patients end up in partly but in psychiatry. Why? Because they somehow either they are despair or either they are underlying problem. So a lot of them are very easily upset with you. Then some of them very violent. Demanding a lot also. So sometimes it can sound like normal, but this you can smell that they are a bit different. And the key thing is, if you're a very severe patient, really just think about this, and the patient may get a bit of help when they come to chemotherapy. Let's say we still have to do a lot of study to prove that it works. Not only they'll give, not they still won't give. Yeah, and so there are things going on, like I can use, like for example, how to detect microscopy, variables, ambulatory. Nowadays they can do ambulatory HRV and gastric myoelectric monitoring. This is why I want to meet like Greg talk about the gastric myoelectric monitoring, autoimmune antibody, and really just how to coordinate clinical service for them, because unfortunately, very hard to cope with this patient. Imagine this patient sitting in front of you, she like, colon, like, stroke already, cannot use. Here cannot use already, so she like have tube coming in. The parents at the back, very difficult to tell them there's nothing much we can offer you, which is nothing much we can offer, because all of them are towards the max already. Unless we find out more about the disease, then it can be helped. No, not then. This kind of patient very, very difficult. No. When to remember?
Sunday morning. Hey, not bad. Monday also can. We run clinic on Monday.
What's wrong with you guys? Purposely do for you one.
We run our clinics on Monday.
Yeah, great.
Okay.
So
sorry.
most refractory DGBI is not SFN. This method is recognition, not universal screening. Glycemic control is important. Neuropathic descriptor, intolerance. These are all outward road subtyping as a red flag. A normal is EMG, NCS, or gastric does not exclude SFN. Skin biopsy is a reference. And Compass 31 is very useful. Try it too. And treat the cause when found. Reserve immunotherapy. And not every DGBI patient has FFN, but every gastroenterologist should at least know about how to suspect it, which is true. With no suspect, then it will happen. So tomorrow, let's say you go for food, then you will know when to suspect also. And so this is my SFN kind of talk. The key thing is, remember, is really nowadays those that you see that are very severe and very young can think about, if they are small fibre neuropathy. I'm not talking about all of them. Young, very severe, you can think about that actually.
Thank you. This is a fantastic lecture. Very learn a lot of this. Maybe might need you to present this again to some of my colleagues from the brain guard and maybe even neuro and things like that, so that we can work together.
Agree.
Yes.
This is, I don't know, let's say later we'll know. Maybe, I'm not sure, because she had problems since 15, not really COVID, but those that are a bit more later and really severe and young, I don't know, so many. Even my patient that we thought that is not, like, the one with this, we think, it must be, like, it's like
super real.
Yeah. Pretty much come back as small fibre neuropathy and started crying. I finally have a diagnosis. Then I said, we like finding shit. But then again, it's just small fibre neuropathy, even they are positive. Is it really all the driving force? For us gastro, we need to know. That's whatever they see in the feed. That's why part of our study is look at the GI part. So whether we actually see, for example, decreased nerve fiber or nerve innervation in the stomach also or not, or in any part of the GI corridor. That's why we are comparing. So, but we know because the other part is very difficult, the autonomic symptoms, those kind of thing. And then a lot of the comorbidity actually is quite similar to DGBI.
Correct.
And can be like the one to have this had NG, the one to have that, or it can also be very severe DGBI. The only difference is if let's say we have no treatment at all, then don't even need to think, don't do it. But the point is there is a possible treatment which is IVIG. So that's why it's important to think about it and find out more. Yeah. But not everyone, And I suspect that after COVID-19, if that is what we think is the real cause, right, the numbers will be quite so we are not triggered yet phenotypic.
We are not catching them.
Yeah.
I have a question to ask. These patients, first question is, do you scope the patients upper, lower, and if you scope them, do you have any findings endoscopically?
No. Most people would have been scoped by other people because these are the people that are very severe, they come in very long, the other people refer to when those cases that refer are very severe kind of constipation, they will say, what about this? Do this. Unless it's from us, actually.
And I ask this because whether or not have there been any opportunities for you to take biopsies, like
small
bowel, your small bowel biopsies, your colon biopsies.
So we already have a DSRB ethical review to get all these biopsy, and we are arranging them to look at what direction to look at things, how to what to stain and stuff. So it's good news that in a way the normal biopsy also can be used to look at nerve, but I need to know whether it can be used to finish the study or not. You can't, the other way that actually Professor Kasim suggests is she's going to do what? A full thickness. What did she say? Can't remember. Transabdominal full thickness.
That one is the
threatening.
Actually, for sometimes when you diagnose amyloidosis, right?
Yeah.
You need to do that. So full thickness abdominal biopsy. So that is one of the techniques for diagnosis of amyloidosis. Is he suggesting the same?
Well, no, for the front. Don't know about the laparoscopic, don't know what biopsy. Very fast. Because if we can, you take the whole chunk to look, that's faster.
So he said that is more sensitive than your so-called
easier to do,
biopsy.
yeah.
Has there been any features like dietary features that you have seen in your cohort, like something that they take excessively? Like we talk about B6 toxicity, energy drinks, that kind of supplements. One thing, and also, or rather, a lack of in their dietary intake in your cohorts. I ask this because Fazima is here.
I myself don't think so, unless the whole of Singapore teens also do this kind of thing, but otherwise not really. They eat all sorts.
Like, well, I know in Thailand they drink a lot of energy drinks.
Yeah, Red Bull.
In Thailand. Yeah, Red
Youngsters
Bull.
nowadays, they are very exposed to
Yeah, Monster lah, Red Bull lah.
distance one,
Yeah.
you know.
And the B6 were very high levels.
True. Yeah. I know it's very easy to buy over in Thailand. But here, jarang lah kan? Got.
And Jaws.
Extra
Yeah,
Jaws.
Monster
something
lah.
like that.
Oh,
Extra Jaws. Yeah, it's available such very easy.
RM2 je per one session, RM2. It's like ready. Sometimes it's at the counter dekat.
Yeah, those kind of like breakfast stalls, they have it like whole sachets.
Yeah, they advertise it.
But it's good.
Try already?
Yeah, I sometimes drink it.
Fizzy.
It's not fizzy.
It is fizzy.
No, it's not. No.
Does it give you the boost?
Oh, I wonder.
I'm not so sure. I just drink it for the flavor.
So that's a worrying part because their B6 is very hard.
Yeah,
The energy
it's very rare for those to get B6 overdose using much of a normal diet.
they also very high sugar also.
Yeah, artificial.
Artificial sugar.
Feed it to the mouse.
Yeah.
I have a question. Do you have idea or do you explore what is the microbiome composition in these patients? Like
Not yet. Yeah, it's something we plan to do, but not yet. Oh.
Prof, is there a guideline for us to follow for this condition?
No, in a way, there's a. I don't know whether you can search Headless lung loss. That is more of a European for Headless lung loss. No guidelines yet, but there may be paper out from us, but but no guidelines per se, because this is still a very new, super new.
Which one are we looking at?
You can put guidelines. I put small fiber. No, put autonomy better. Not SFN.
And heads are.
So even in my practice, I see two cases like this. So one is associated with SLE, very young female with SLE and pan dysautonomia, upper GI symptom, lower GI symptom, and very difficult to treat. You give them medicine, medicine also that's over. At the end, she ended up having collapse. So very poor prognosis and very difficult to treat.
Oh, there we go. Heads diagnosis criteria.
No, later.
This one?
Yep.
Aziz Kasim
Constipation. So the constipation is better, but of course the other part of the symptoms, she still has a bloating. I haven't actually heard from her after that. I need to follow up also what happened after this.
Now another question is, out of the
So you can see, this is also quite new. This is quite new, So we actually, talked to all of us, three of us here. When Qasim Aziz was here, so he presented to us on this topic. Yep. Your question is?
Because just now, Prof give a few modalities to actually sort of diagnose in your cohort. What are the criteria that you need that you say is a proven? Yeah. So at least for us to say that this is the proven SFN.
Oh, proven. Okay, wait, step by step. So you suspect someone may have dysautonomia problem, GI dysautonomia, then you use the compass to do that. If it's more than cutoff point, you're comfortable in 20, then actually you suspect that the patient may have small fiber neuropathy. Then, depending on what you have, Q-sat and the port is the easiest. Tilt table, so it's easier. If not, if you want to go one further, look at the eye. If you know how to look at this kind of eye, some kind of impairment of the eye called autonomic system. After that, these are getting more and more difficult to get already. It's like, you have to get all those other equipment. But to diagnose for possible, you actually don't need so many things. Just this the diagnosis of things, and then one Q set, one Q sort, already enough. But it's not big, it's not difficult. Even the confocal microscopy, it's just that they stop producing. Yeah. And also tilt table is supposed to be very standard tests for cardio, just that your cardio don't have. Yeah.
So is it enough if you're suspecting maybe positive from the question corpus, and then pair with a tilt table, is it enough to make a diagnosis?
The diagnosis normally at this time, I still make my neurologist. But if you have two at least it's positive, it's likely to be positive.
I sense where you are coming with this line of questions, because with our current setting, we might have limitation to access.
Yeah.
Right. So therefore now if I were to take it one step further from you, whether or not would we be willing to adjunctively treat within reason, like we give very low doses of midodrine, see whether they respond. Oh, they respond. Can we say that this is going to be? Can we say that this is SFN? I mean,
the answer is I don't know.
Yeah.
You're talking about another kind of way of doing things. Huh?
Yeah,
If they don't accept one, you will just accept.
KK.
Because I was thinking,
Yeah.
I can do the contrast.
Yeah.
I can try to ask for the tip table.
Huh.
But the other test I think is very difficult.
Yes, correct. Correct.
Not by us. For
Yeah.
yourself.
Yeah.
I think the tube table thing should be okay.
That one,
We can two table.
Yeah.
Yeah.
Oh.
But the biopsy, the others.
Biopsy very difficult. Biopsy have to send to Mayo, those kind of thing. That's why I say to do a definite test, still difficult unless that I'm not sure whether if the neurologist just start everything here in Asia, we're just going to follow one rule. Can or not, don't know. Plus there's still a lot of control.
So the biopsy has to send to you.
Yep.
So it's not by.
Oh no, sorry. Not the biopsy. The blood reagent mixture. We now send by ear also for any endo antigen. And also they use the biopsy itself. They have to follow certain criteria. Now it's Mayo criteria.
For the skin biopsy.
Yeah, correct. But do we have enough local? No, normal review. I don't think so.
And also you said that they need to look at the marker, the PGP 7.5 in the skin biopsy.
Inflammatory markers not useful, often normal.
Only a few. And those are GI inflammatory markers, but very small in here. It cannot be because of the number not that big. Then curiously, told them that in China there is not much